and gentlemen, welcome to day 4 of a very long marathon challenges in hematology, which has got the best of EHA 2022. Under the aegis of Mumbai Hematology Group, we are extremely proud to present the same. All courtesy our program director and Mumbai Hematology Group. We know him very, very well, Professor Dr. M.B. Agrawal, President of Mumbai Hematology Group, inspiration, teacher of teachers, and many accolades to sir's credit. A warm welcome to you, sir. A warm welcome to all the experts who are going to speak to us today, Professor Rees and others. And a very, very warm welcome to our expert discussants who are going to log in today to make this a very interactive session. Last but not the least, all the delegates who are joining from various parts of the world, a warm welcome to all of you. May I request Professor Dr. M.B. Agrawal, sir, to take it forward from here.
Thank you, Dr. Manoj, and good evening to one and all, and good afternoon and good morning to others from various other parts of the country. Challenges in hematology, including the best of EHA 2022. Today, this webinar is brought to you by Mumbai Hematology Group, supported by INTAS. And I must thank Dr. Manoj Kumar and his team specially for totally taking care of this whole symposium's sponsorship, without which it was not possible. It's not just this event, but we have been grateful to INTAS for all the support towards our academic activities for last 2 decades. Perfectly managed by Perfect Square. So our thanks are to Dr. Manoj Kumar, his team, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. All our discussants were themselves eminent hematologists and medical oncologists, new participants from 20 plus countries for sparing your Thursday morning, afternoon, or evening. Do go to our website, www.mhgindia.com. You will get all the information about our academic activities, not only during the month of July, but also August and early September. Today is day 4 of this series of webinar. Our first guest speaker is Professor David Rees from London, UK. Professor Rees is a consultant pediatric hematologist at the prestigious King's College Hospital, London. He has a special interest in sickle cell disease. He was trained in Cambridge University and St. Thomas's Hospital Medical School, University of London. He then worked at Sheffield, Oxford, and London hospitals before being appointed at the King's College Hospital, London. He has many years of full-time research experience in lab and clinical aspects of inherited anemias. He's published over 100 research papers in peer-reviewed journals on these subjects. He's a member of the steering group of the NHS Sickle Cell and Thalassemia Screening Committee, a medical advisor to the Sickle Cell Society. He's also an editorial board of the British Journal of Hematology. His research interests include understanding more about the causes of variation in sickle cell disease, and particularly the cerebrovascular disease. He's also interested in mechanism of red cell damage in sickle cell disease, including cellular dehydration. He's involved in the care of over 1,000 children with sickle cell disease in southern London and a medical advisor to the Sickle Cell Society. Today, he's going to speak to us on precision medicine in sickle cell disease. Over to you, sir.
Thank you. Thank you for inviting me to talk at this nice meeting. Do I share my screen?
Yes,
sir. Yes.
Go ahead, sir. Share your screen.
Can you see that?
Yes, we can see it.
I will put it in full. Is that okay?
Perfect.
Good. Well, as I say, thank you for inviting me to talk at this meeting. I'm sorry I can't be in Mumbai, but it's still nice to be able to take part. Just a brief bit about sickle cell disease, which is overall thought to be the commonest severe inherited disorder in the world, although the exact number of patients is not really known. There are lots of estimates, and the broad estimate is between about 3 and 6 million people in the world. Of these, about 70% are in the continent of Africa. There are slightly better figures for the number of births per year. And in Africa, there's thought to be about 250,000. And then in India, a very large number of 40,000 births per year, about 10,000 a year in the Americas and the Eastern Mediterranean, including the Gulf. And in Europe, a fairly small number of 2,000. But even in Europe, that still makes it the commonest severe inherited disorder, more common than cystic fibrosis and hemophilia, for example. All the sickle cells, there's different genotypes cause it, but they all are caused by the same variant in the beta globin gene, which creates sickle hemoglobin, hemoglobin S. And this is the distribution that I've just really mentioned that everyone knows about, really, that sickle is common all over the world, or it occurs all over the world, but it's very common in certain regions. And those regions tend to be areas where malaria is or was particularly common, mainly because being a carrier gives some degree of protection against dying from malaria. In India, I think it's a complicated picture, but there's a variable prevalence with quite high levels in some ethnic groups. They're thought to be 2.5 million sickle carriers, and the numbers are high, the 40,000 births per year in India, which makes it the third highest in the world of number of births after Nigeria and the Congo. Again, it's a very rough estimate. There's thought to be about 120,000 individuals with sickle cell disease, but again, they seem to be concentrated in certain areas. From the UK perspective, it's slightly odd in that we see there is a large number of people of India, very large number of people of Indian origin live in the UK, but we have almost no Indian families with sickle cell disease. I know we see none at King's, and in London there are very few, whereas there are smaller numbers of people from West Africa, but we have huge numbers of sickle cell disease patients from those families. And again, I think certainly it's never entirely clear to me why there is that slight paradox between the very large numbers in India and the very small numbers in the Indian diaspora, at least in the UK. In general, it's linked to a single haplotype, a single beta globin background that's associated with high hemoglobin F levels, which traditionally is associated with a less severe clinical problems than in the more typical sort of West African type sickle cell. Although the studies that have come, and there have been quite a lot of very good studies coming from India looking at sickle cell disease, do show really that there are very significant clinical problems associated with it. And it's not the sort of mild silent condition that perhaps people at one point thought it was. Going on to the pathology of sickle cell disease, really, it's, as I say, it all starts with a single base change, which causes a single amino acid change in the beta globin chain. And that leads to hemoglobin S polymerization. The beta globin is only expressed in the red cells, really. And that one small change in one cell type leads into a whole cascade of sort of complicated pathology and a severe multi-system disorder. Almost everything you can measure in sickle cell disease is abnormal. But the damage to the red cell spreads throughout the whole body, really. And probably the two primary pathological processes are vaso-occlusion and hemolysis, so that you block up small blood vessels, and you also release the contents of red cells into the circulation, which are quite toxic. And as I've said, you can measure almost anything in sickle, and it is or nearly always abnormal. And there's evidence of bone marrow infarction. It's an inflammatory state. People are anemic. There's a functional nitric oxide deficiency. They're hypercoagulable. There's oxidative stress and reperfusion injury. They're hypoxic. They have vascular damage. They're prone to infection, and they have organ damage. So at one level, it's a very simple disease. At the other level, it's a very complicated disease, which is relevant really to talking about precision medicine. Going on to the precision medicine aspect, strangely, for a term, precision medicine isn't very precisely defined, and the people, you mean different things when they talk about it to different people. But the general principle is that you should, rather than treat everyone with the same disease the same, you can choose different treatments for different groups of patients based on particular features, particularly genetic features. And typically the choice of decisions is made using genomic or molecular information. And the driver from this has really come from leukemia and malignant conditions where there's the more genetic diversity is perhaps more apparent. There are other terms that people use, like personalized medicine, targeted medicine, stratified medicine, and deep phenotyping, which all have slightly different meanings, but are basically the same idea. And the same, it is the basic idea of medicine that you should treat everyone differently, really. They're all individuals, and it's possibly just stating we should just call it medicine rather than precision medicine. But for precision medicine to be meaningful, various things have to apply. There has to be variable clinical outcomes. There has to be a validated way of identifying the different groups, and then there has to be a range of different treatment options. And you have to be able to predict who will respond to the drugs in certain ways. And then there has to be the availability of diagnostic and treatment facilities. There's no point being able to do all this if there's no one can actually do it because it's too expensive. And I'll go through each of these briefly to just talk about how they apply to sickle cell disease. So in terms of variable outcomes in sickle cell disease, then it's definitely yes. It's like many diseases, it's famously variable really, and almost every phenotypic aspect you look at varies hugely in terms of who's affected. Pain is the hallmark symptom of sickle, with people coming into hospital with acute vaso-occlusive pain. And although on average there's about 1 or slightly less episode of pains per year, that varies hugely. And a study 30 or 40 years ago now showed that clearly. And it's, again, anyone who looks after people with sickle cell disease knows this on a daily basis, that that some children and adults are very severely affected, and they get, in this study, about 1% got 3 to 6 episodes of pain, and nearly half of them never had any episodes of pain per year. This was defining pain as pain requiring attendance and admission to hospital, and obviously exactly how you define pain and how you define your phenotype alters how variable it is. But it's certainly the case that it is very, very variable. Cerebral vascular disease is another aspect that we're interested in that I will talk a bit about later, and showing that again, about 40 to 50% of patients with sickle cell anemia have some evidence of neurological damage by the age of 14, even with optimal care and with primary stroke prevention programs. And that damage can include overt infarctive stroke, silent cerebral infarction, increased transcranial Doppler velocities, which is due to damage to the large arteries in the brain, intracranial hemorrhage, or even extracranial blood vessel damage in the neck. And this spectrum occurs differently in everybody. As I said, half the people don't have it and half do. And in very simple terms of precision medicine, can we predict the half that are going to get it, and can we stop that 50% from getting it? So definitely sickle cell disease is variable, and it ticks that box very strongly. The second question is more difficult really, and can we predict outcomes in sickle cell disease? And as I said in the first sentence, we can to some extent, but the majority of variability is largely unexplained. As I've mentioned, everything is abnormal in sickle cell disease, and there have been a very, very large number of biomarkers described that are abnormal in sickle cell and correlate with something or other. Almost every month, almost every time a publication on sickle comes out, there's a description of a new biomarker. People discover a new cytokine or a new interferon and measure it in sickle, and it's normal, or it's abnormal and it correlates with hemoglobin or something. But none of those, despite there being more than 100, more than 200 such molecules, biomarkers described, none of them have proved to be clinically useful, in the sense that none of them are routinely used. And none of them give any more information currently than simple tests such as measuring the hemoglobin level, measuring the hemoglobin F percentage, the reticulocyte percentage, and the white cells and neutrophil count. So although biomarkers have been identified and described, they currently don't reliably predict outcomes in sickle cell disease any better than basic hematology. There's a limited but important role for imaging techniques, particularly for transcranial Doppler scans, which I'll mention later. And there's limited but increasing evidence from genomics. There are quite a lot of big-ish genomic studies in sickle cell disease, which I'll discuss briefly. But to date, none of those have really reached the degree of sophistication or usefulness that you see increasingly for treating acute leukemias and conditions like that. This is just looking at some of the useful biomarkers, and this is your two categories showing stroke in children, one of the more severe phenotypes really, with one category showing 25% and the other having less than 1%. And that particular bit of precision medicine is by measuring the transcranial Doppler velocity, the test that was first described for sickle about 30 years ago, where you can pick up children who've got damage to the middle cerebral artery fairly early on. And that as measured by the blood flow in the arteries in their brain, and that predicts who's going to have a stroke and who's not, and that, which is important. And the other very important thing is that there is a way of, if you transfuse the children with high TCD velocities, that reduces the risk of stroke to 90%. So it's not the typical genomic example of precision medicine, but it is a good way in which, precision medicine does work. You can identify high-risk children and you can reduce the stroke risk. Secondly, obviously, death is the ultimate phenotype, really, and this is looking at death rates in sickle cell anemia, showing that one group, the under 5 mortality was very high at 8 per 100 patient years, and the other group, it was almost undetectable. And again, this is obviously, being able to make this sort of prediction is very important for precision medicine. And the key factor in this is where you live, really. And this is in Tanzania versus England. Tanzania children were looked after in a sickle cell centre with optimal care, but even with that, then there was still a significantly increased risk of death. And again, it highlights one of the problems with the idea of precision medicine in sickle cell disease. These are genetically very similar populations. The population with sickle cell disease in the UK, as I said, are predominantly of African, West and Central African origin, and there are genetic differences between the Tanzanian sickle patients and the patients we see, but not very marked. And this marked difference isn't a genetic factor. Fairly obviously, it's due to social and environmental factors and exposure to malaria and access to certain treatments like blood transfusions and antibiotics and hospital intensive cares and that sort of aspects, in the presence of screening things. So when you have very marked differences like that, which definitely occur but are not due to genetics, it makes it, within a global context, it makes the idea of precision medicine quite difficult. And the third example of this I'll show you, which is some work that we've done in the patients we see at King's, looking at the flow of blood in the cervical carotid artery in the neck. And as I mentioned, that is linked to complications of cerebrovascular disease, so that children with high velocities are more likely to get strokes. And we identified a biomarker, a factor, which allowed us to identify those with high and those with low. And that biomarker was their month of the year that they were born in, that those born under the sign of Scorpio had much higher velocities than those of Aries. And this is a real result. I haven't made it up based on the statistics that we did. But the reason why although it's real, it's also nonsense, is that, there are several problems with the way we looked at it. We analysed a lot of different things before finding this. And if you analyse enough, you can always find some difference. Obviously, this has not been validated in any other populations, and it almost certainly wouldn't be. And it also doesn't make sense. It's not a plausible association. And the reason I show that isn't just for a laugh, really. It is that there are so many studies like this published in sickle cell disease and other aspects of medicine in general, but particularly sickle cell disease. As I said, although obviously Scorpios and Aries are nonsense, then if you replace Scorpio with a particular level of interleukin versus a high level versus low level, or a particular genetic variant in a particular gene, then papers like that are published all the time, which are really just finding associations which may or may not be plausible, more plausible than this, but have no link to causality. And one problem in sickle is that everything is correlated to the first process, the rate of polymerization, so that the fact that you get a high level of one particular interleukin, it nearly always correlates with something else, correlates with something else, correlates with something else, and that all correlates with the underlying rate of polymerization. So the other problem with precision medicine in sickle cell disease is that there's a lot of rubbish out there. There's a lot of very kind of studies done which are true in the statistical sense, but are not meaningful and cannot be reproduced. I think that's true of sickle, definitely, but it's probably true of many types of studies like this. And one of the effects of more powerful genomic techniques is that people are realizing now that this isn't really a very useful approach, that you can identify candidate genes or variants in candidate genes, and you can show there is an association in a certain population, but those are very rarely validated. And whilst there have been a lot of candidate gene studies in sickle giving positive results, almost none of them have been validated in a second population. So going on to genomic analysis in sickle cell disease, there are some things which are known to be significant, and those are really the beta globin genotype, the alpha globin genotype, factors that determine hemoglobin F levels, and then the genetics of specific complications, which I'll talk about briefly. There are many different types of sickle cell disease. There are more than 15 different beta globin genotypes. The common ones, people, are SS and SC, and S with beta thalassemia. SS and SC are the common two that we see, but in our African American population. But in India, then SS and S with beta thalassemia are the two big genotypes. And there's some similarities, but there are also very significant differences. And the very simple approach to precision medicine would be to have a different treatment approach for each of these conditions. Unfortunately, there's very little evidence on treatment except for hemoglobin SS. As I mentioned, the two groups, we see about 30% of the patients we see have hemoglobin SC disease. And this is a simple blood film comparing the two conditions, showing at the very most, even at the most basic level, they're very different. The SS patients have these typical sickle cells with very acute angles, and the SC patients, you don't see that generally, but you do see these folded boat cells or pita bread cells, but the basic morphology is very different. But in practice, we group them together and treat them the same. Again, this is data from our patients comparing basic parameters in SS and SC, showing again that everything is significantly different apart from age and vitamin D level as a control. But the hemoglobin is in SC, the hemoglobin's higher, there's less hemolysis, the white count is lower, the hemoglobin F is lower, and Doppler velocities are lower. So the general trend is that everything is less severe in hemoglobin SC than SS. And the basic pathology is different as well. In SS, obviously the problem is primarily pneumonization. In SC, pneumonization occurs, but it seems to be that it's red cell dehydration is the main problem, which concentrates the hemoglobin S and causes the polymers to form. The polymers are part of it, but the fundamental cellular pathology is probably different. So you'll think these are very different diseases. They're both common. We have, as I say, 30% of people with sickle cell disease have SC. So that's, at least 1 million people worldwide. You'll think there would be different treatments, but in fact, we have no evidence-based different treatments for SS and SC. They're both given penicillin from infancy, and it may be unnecessary in hemoglobin SC. Hydroxyurea tends to be used there's a lot of evidence for its use in SS, but very limited evidence in SC. And there are possibly some specific treatments for people with hemoglobin SC disease, but again, little evidence to support their use. In general, venesection is offered if the hemoglobin is high. The red cells, as I mentioned, tend to get dehydrated due to losing potassium particularly, and you can inhibit some of those channels. One of the channels is called the Gardos channel, and it's possible to inhibit that. And eye complications are more common in SS than SC. And one very simple approach, which hardly qualifies as precision medicine, is to get people with SC to have regular ophthalmology reviews. Why is it not changing? So basically, there are lots of, and you could do the same comparison with S versus S beta thalassemia. There's less data on that, and there is, again, fairly good data from India comparing the two. But at the moment, the tendency in sickle cell has been to group it all together just to try and get some semblance of treatment and understanding. But again, the same as like leukemia in the early days, it was all grouped together and treated in the same way. But we should now be moving to a more sophisticated approach where we look at the different types of sickle cell disease and try to get specific treatments for them. Because none of these are rare conditions. S beta thalassemia is a very common condition, and millions of people have it, but we know very little about it. Alpha thalassemia is common. It's the commonest single gene disorder in the world, not generally harmful, but maybe 10 or 20% of the world's population don't have the typical number of 4 alpha globin genes. In the sickle population, about 40 to 40% of patients have some form of alpha thalassemia. As I'm sure you largely know, most people typically you have 4 alpha globin genes, 2 from each parent, and but it's very common to have 3 or 2, and both of those are generally called alpha thalassemia. That result, the net effect of that is that if you have sickle as well, it reduces the concentration of hemoglobin in your red cells, which in turn reduces the rate of hemoglobin S polymerization, which is heavily dependent on the concentration of hemoglobin S. And so overall, it has a beneficial effect to co-inherit alpha thalassemia. You'll predict, and as I'll show you, does lessen the severity of the phenotype. Alpha globin is also possibly expressed in the vascular endothelium. There's quite a lot of evidence that it may be, and some possibly alteration in the expression of that may have some clinical consequences. Overall, as I said, co-inheriting alpha thalassemia with sickle cell disease is a beneficial thing. And there's a reduction in incidence of most of the life and organ-threatening complications. The one thing that doesn't seem to reduce is the frequency of pain and vaso-occlusive complications, which has possibly increased, and very few studies show any decrease. This is our data looking at alpha thalassemia this is in 400 odd patients in these two graphs, just showing the effect on hemoglobin level, which is very significantly higher in those with 2 alpha globin genes as opposed to those with 4, the normal situation. So alpha thalassemia in general associated with high hemoglobins, which in general is associated with better outcomes. Similarly, the white count is lower if you've got 2 alpha genes versus 4 alpha globin genes. So alpha thalassemia causes a lower white count, which again, high white count is associated with worse outcomes in sickle cell. And it may be that, overall the lack of polymerization means there's less inflammation, so the white cell count is lower. So it may be an incidental sign that there's less polymerization, or it may in itself be beneficial. And this graph here looks at the transcranial Doppler velocity, the measurements I mentioned earlier, in those in the red line with 4 alpha globin genes, and in the green line those with 2 or 3 with alpha thalassemia, showing again a relatively small but very clear statistical difference between the velocities measured at the different ages in this study, which is of more than 1,000 different readings. And again, that may look like a small difference, which it is, but we know that is an indicator really of other things going on, of vascular health and of the hemoglobin level. And we do know from other studies and the studies that we've done that alpha thalassemia protects against the risk of cerebrovascular disease in quite a significant way. So you'd think that maybe we would measure alpha thalassemia, and I'll come on to that, but I'll come on. Basically, although it has a very marked effect, we perhaps under-measure it and underutilize it. One question is always, the one treatment that's used in sickle cell disease is hydroxyurea. And one question that arises is, does alpha thalassemia affect the response to hydroxyurea? And some people have suggested that if you have alpha thalassemia, you don't respond as well to hydroxyurea, which would be interesting from a precision medicine's point of view, and that this would be one factor that would help you choose particular treatments. In our study, we didn't really find any difference in terms of the change in percentage hemoglobin F or the change in hemoglobin. There was nothing to suggest that if you had alpha thalassemia, that hydroxyurea was less effective. So in summary, alpha thalassemia is quite difficult to identify. You have to do, the DNA testing isn't straightforward. It used to be you had to do southern blotting, and even today, although there are PCR tests, none of them are straightforward. So it's we don't routinely measure it in our population. We measure it in quite a lot of them. We try to, in the sense that at the very least it does give you some prognostic information. You can say to the parents, maybe children with alpha thalassemia, they'll hopefully do well. They're less likely to have severe complications. Although it's nowhere near being a 100% guarantee that you'll be well if you have 2 alpha globin genes. So it's not routinely measured in, I don't think it's in any population, and it's still, although it's getting easier, it's still an expensive and difficult test to do. It probably doesn't affect the response to hydroxyurea, and it's not usually considered in clinical trials, but clearly it is a relevant factor if your endpoint is say a change in your hemoglobin, and we know alpha thalassemia alters your hemoglobin, then it may well be a factor in determining your response. So new drugs like voxelotor, which works by increasing hemoglobin but of uncertain benefit, it's probably maybe important to consider your alpha thal status in terms of determining how people respond or benefit from drugs like that. the potential use of alpha thalassemia in precision medicine is significant, and it is one of the few genetic markers which has a strong effect on phenotype in sickle cell disease. As I said, it does provide for reasonable prognostic information for parents and families. There is a clear difference in the risk of stroke if you have alpha thalassemia, so potentially different stroke strategies could be adopted. And as I said just now, really, it may affect how new and emerging drugs work, and potentially drugs. There are quite a few drugs around at the moment that may be beneficial by increasing the hemoglobin, and clearly alpha thal may be a significant factor in choosing whether patients benefit from that. And going on to the third factor, which most people know about, is the hemoglobin F level, fetal hemoglobin, and that for 50 years, 60, 70 years, in fact, people have known about this now. And Janet Watson in the 1940s noticed for the first time, really, that babies didn't have any symptoms of sickle cell disease, and it really didn't have any symptoms at all, or very few, for the first 6 months. And she related that correctly to the idea that they had lots of fetal hemoglobin when they were born. And since then, there have been a huge number of studies done looking at the effects of hemoglobin F and potential benefits. And overall, it comes out as a very beneficial factor. Higher F levels are associated with increased life expectancy, reduced frequency of acute pain, and reduced frequency of leg ulcers. But there's one factor that they don't seem to alter significantly, at least in the range seen in the normal population of sickle cell disease patients. They don't reduce the incidence of cerebrovascular disease. But F is known. There have been a lot of studies done to try and understand what determines the levels of hemoglobin F, which genetic factors. And overall, it's known that depending on which population you look at, about 20 to 50% of the variability in hemoglobin F is of genetic origin. There are three main loci: BCL11A, which was identified by my colleagues here at King's, HBSL1, MIB, and HBG2, the gamma globin gene. Those are the three sites at which variants have been found that control the hemoglobin F level. And people have looked, there have been quite a lot of studies done looking at genotyping people at these levels, or combining these genetic areas into a single sort of measurement, a single score that gives you a genetic risk. And overall, those have all been quite disappointing. They may predict hemoglobin F level, but in general, they do not reliably predict outcomes. So you can measure the hemoglobin F level, which is useful, but the genetic testing doesn't really, it gives you less information than measuring the hemoglobin F level, and it doesn't reliably predict those people who will get frequent pain or length of survival or anything like that. It also doesn't reliably predict who would respond to hydroxyurea, which again, in terms of precision medicine, is quite an important factor to try and work out who will benefit best from this drug. And it doesn't seem to be determined by the hemoglobin F levels, or by the genetic factors controlling hemoglobin F. And then the other group of genetic factors which are important and have been found are those that have been found in non-sickle populations to be linked to certain complications, and then they're also true in sickle cell disease. One example is the inheritance of Gilbert's or Gilbert's syndrome related to the UGT1A gene promoter, and the number of TA repeats in that, and that's been strongly linked to the presence of high bilirubin and gallstones in the non-sickle population. And the same association is true. The children with sickle cell disease who are more jaundiced, and those who are more likely to end up with gallstones and needing a cholecystectomy, are those who've inherited Gilbert's. So it would be possible to test people at birth or at some point to identify those at high risk and potentially take their cholecystectomy, their gallbladder out electively, to avoid them developing gallstones and developing cholecystitis. I don't think anyone practices that currently. Some countries, like France and some places in the Middle East, do regular ultrasound scans of the gallbladder and take the spleen out as soon as gallstones develop, before symptoms are established. In the UK, and I think most countries, then in general, gallstones are left alone unless people develop cholecystitis, the idea being that lots of people have asymptomatic gallstones. The other, one of the other severe complications in sickle cell disease is nephropathy, and about 30–40% of adult patients in some countries, certainly in the UK, die of renal associated complications. And it is possible to predict who's at increased risk of significant nephropathy by looking at the APOL1 gene, and the G1 and G2 variants are associated with a higher risk of renal impairment. These were identified in non-sickle populations, and the same association has been confirmed. Again, it gives the potential for starting ACE inhibitors or treatment early to prevent damage, but that currently hasn't been done, and people aren't really looking at it. I've mentioned really probably the major phenotypes in children with sickle cell disease is cerebrovascular disease, and stroke is a devastating complication when it occurs, in the sense that it causes significant cognitive and physical impairment, and it's very difficult for children to go on and achieve their full potential once they've had a stroke, and many are very disabled and unable to live independently. As I mentioned, it is possible to identify children at high risk of stroke by TCD, and you can reduce that by 90% by transfusing those. And although that's a nice example, it's fairly crude and doesn't really fit well with some of the complicated approaches to precision medicine being used in other areas. So we've looked at, and other people have, we've been doing genetic studies to try and understand a bit more about the risks, to try and refine the use of transcranial Doppler scan and avoid transfusing children who aren't going to have a stroke. And currently about 40% of children with abnormal TCDs do not require transfusions, in the sense that they wouldn't have had a stroke. And that's a considerable waste of resource to transfuse people unnecessarily. The other problem is that there are other forms of cerebrovascular disease not detected by transcranial Doppler scans, including silent cerebral infarction, extracranial vasculopathy, and subarachnoid hemorrhages. And potentially you can identify, these factors, use these people more likely to get these complications using genomics. One approach that we've done various studies, but one approach we took, one difficulty with these genetic studies is you need very large numbers of patients. Like in the genome-wide association studies looking at hypertension and stroke, they use tens of thousands of patients to get a significant association. And although sickle is a common disease, in some ways it's actually quite a rare disease in other ways. And to find tens of thousands of people with stroke is difficult with sickle cell disease and stroke. And most of the studies use about 1,000 patients rather than the larger numbers. One approach around this is to try and use extreme phenotypes. So we looked at one end of the very severe end of the stroke spectrum, which is children who had stroke at a very young age, before the age of 4 years, and didn't include anyone who had a precipitating event. Some children have strokes following severe illness like acute chest syndrome or meningitis, and we excluded those. So these were otherwise healthy children with sickle cell disease who had a stroke, and when they were very young, before the age of 4 years. And we have about 5,000 patients to go through, and we identified 19 patients who fitted that criteria, meaning that it is quite a rare phenotype. And we did whole genome sequencing of these 19 patients, mainly really to see if there were any major candidates. So we're looking for important disease-causing genes, which would be very rare in the general population, but would stand out in a population like this who had stroke at a very young age. And the average age of stroke was 3.3, and they had typical sickle cell strokes with infarction in the middle cerebral artery. They had less alpha thalassemia than expected, which is possibly what you'll predict. And they were also more anemic at the age of 1 year than you would expect, with a mean hemoglobin of 66, whereas the average hemoglobin in sickle at that age would be more like 80. And going through using really trying to do two things: picking out any rare variants that was in a gene that was associated with stroke or complications of sickle cell disease, and occurred in one or more of these patients. And there were a few potential candidate genes pulled out, but the things that stood out were the large number of variants in ApoE, which is a gene that's been studied a lot in human disease as a cause of brain disease, Alzheimer's, and stroke in the non-sickle population, and to do with lipoprotein and omega fatty acid metabolism, which are again relevant to the risk of stroke and sickle cell disease. So of these 19 children, 13 of them had a particular ApoE genotype, which is relatively uncommon in the general population. 2 other patients had further, in fact, 4 other patients had further abnormalities in genes linked to cholesterol and LDL in lipid synthesis. So overall, about 17 of the 19 patients had abnormalities in their in genes associated with fat metabolism. We've obviously, as I said earlier, it's fine to find these results, but validating them is always the difficult thing. So we validated. We went on to look at another section of older adult patients, older children and adult patients of 283 children who had had a overt stroke, and compared them to a similar population who hadn't had stroke with sickle cell, and again found an excess of these ApoE genotypes. So the 2,4 and the 4,4 genotype was associated with a very significant increased risk of stroke of about 4 in this population this was in the older population as well. So potentially, and again, this is work, it has been published now, but it is still early work that we're still developing. But it's plausible in the sense that abnormality, this is a gene that's been implicated in stroke in the non-sickle population, and it alters lipid metabolism and vascular health. So it's plausible that it could be associated with the stroke. And it is also important because it's potentially modifiable. You can change diet, or you can give drugs to alter the lipid profile of children and potentially modify the risk of strokes like this. Although it hasn't really, it's still early days and we haven't established it as routine clinical practice, it is potentially an area where precision medicine might start merging into sickle cell disease, where we can further refine the identification of children at high risk of stroke. So moving on to the management of sickle cell disease, obviously another prerequisite for precision medicine is that you do have lots of treatments to choose from, that you can do your complicated analysis, you can have 10 different groups of patients and you have 10 different treatments available. That isn't the case with sickle. These are the current management of sickle cell disease. There are some treatments that are recommended given to everyone, which would be penicillin and more or less hydroxyurea. And in countries where there's malaria, protection against malaria, then there's some that are given by expert opinion, really. There's not much evidence for them, but they seem like a good idea, which is things like stem cell transplantation. Examples of precision medicine, really, it's only really a regular blood transfusion for primary stroke prevention in children with abnormal Dopplers. And then there are new treatments, which there's very little evidence on how to use them. And the 3 current ones which are licensed in some countries and not others around the world are crizanlizumab, voxelotor, and enzalutamide. None of these are very powerful drugs. They don't have major effects, but it's not entirely clear who should be given them and who should benefit from them. So going back to the list of requirements for precision medicine and sickle cell disease, are there variable outcomes? Yes. Are there validated ways of identifying prognostic groups? No. Is there a wide range of treatment options available? No. Can we predict response to drugs? No. And is there availability of diagnostic treatment facilities? Well, there's not really. And the point of the last one in particular is the fact that the vast majority of children with sickle cell disease live in low-income countries or middle-income countries. And the idea that we can whole genome sequence all the children in Africa with sickle cell disease and choose, even if there were drugs available, then the idea of the cost of that obviously is unimaginable at the moment. So we're so far away from precision medicine being useful in sickle cell disease. It's it's something to think about, really. And there are, in terms of improving the health of people with sickle cell disease, there are things that need to be done before that. That's not to say that we shouldn't be working in this direction and that this is how we should be treating people. We should be identifying people and having a range of treatments. And progress is being made around that, as I've tried to touch on today. But at the moment, it's not possible to say that precision medicine is important or applicable to sickle cell disease. So this, going back to this diagram, really, that's partly because it is complicated, really. There are so many factors and they're all intercorrelated. And although you can treat inflammation, that doesn't necessarily, it's bypassed by all the other processes going on. Where the scope for precision medicine does come in is looking at these different boxes and trying to work out which patients have more problem, the balance in different patients may differ. Some people are more inflammatory, others are more hypercoagulable, some have more infarction, some are more anemic or hypoxemic, and to try and choose treatments to fit with the particular pattern that we see. The other issue is, why is it difficult to predict outcomes? And without going on too much about it, then one of it is the things I've talked about. There is a lack of understanding of genetic markers, and a lot of the genetics is done in essentially a European or white population, and we still are relatively short in genetic studies and genomic understanding of people of African and Indian and Arabic origin. There are no very large multinational studies, and the largest studies are about 1,000 patients. The other factor, which again I touched on earlier, really is that environmental factors are very important in sickle cell, and it's fine, finessing all the genetic factors, but there's still, huge effects of poverty and income, and even in people with the same socioeconomic status, environmental factors are important, and the association with weather and environmental and sort of cold weather and factors like that, again, are well known in sickle cell disease. And for example, to show you how difficult it is, we did quite a big study in London and Paris to try and identify environmental factors associated with increased episodes of pain. And we found that rainy weather was associated with increased emissions in Paris, but not in London. And obviously these are similar sized cities, very close together, slightly different climate, but even in culturally quite similar populations, there were significant differences in the way the environment interacted. And that may be that French people are more elegant and they don't put on clothes when it gets cold, whereas English people are wrapped up in warm coats the whole time. I don't know, but it is complicated, and genetic factors are part of the complexity, but they don't explain all of it. I just really said that there are a lot of environmental factors to consider, and they have a major effect, probably more than genetic factors. And this is just one illustration of that. There's lots of nice studies done. Well, some studies done in looking at environmental factors, and this wavy line is looking at sickle cell disease in the UK, and the peak goes on at winter. Each blue line is winter, and these are years over a 10-15 year period. And the question is what this wavy line is, and it in fact is the number of searches on Google for sickle cell disease, showing as a very sort of kind of interesting but quite blunt way to look at how much interest there is in sickle cell disease, showing that every winter people become more interested in sickle cell disease and start searching on Google for it more frequently. And that was shown in two it's shown in other countries as well. In contrast, myeloma, which doesn't have a seasonal effect, had no such variation. So environmental factors are undoubtedly important. So looking to the future, this is how precision medicine could turn out, that we have a range of treatments. We have 6 or 7 treatments, and currently we have L-glutamine, and that could be chosen for people with increased oxidative stress. We have crizanlizumab, which is a P-selectin blocker, and maybe people who express more P-selectin would benefit from this. And voxelotor increases oxygen affinity and increases hemoglobin, and maybe people with low hemoglobin levels benefit. Emerging drugs include mitapivat and etavopivat, which increase hemoglobin by stabilizing pyruvate kinase activity, and possibly we could test people with low pyruvate kinase levels and give them those. Canakinumab blocks inflammation, so children and adults with high CRP may benefit from this. Vamifeport is a ferroportin inhibitor that reduces the red cell concentration in red cells and reduces the rate of polymerization, so children or adults with a high MCHC may benefit. And Seni-K-POC is a Gardner's channel blocker, so children or adults with leaking red cells could have this treatment. So in theory, we could develop, when we do have all these assays available, we could identify who's got this particular problem and choose the right spectrum of drugs to treat the pattern of disease that they're getting. In theory, that may happen and may be possible. At the moment, it's hugely expensive. All these drugs, they all cost, in UK prices, £40,000 to £100,000 a year. So the idea that you could even in the UK, it's unaffordable to put people on 5 or 6 of these drugs, lifelong is very unaffordable. But things may change, and these are, they're expensive for complex political reasons, and they're not necessarily intrinsically expensive, and that may change. So in summary, in terms of improving the health of sickle cell disease, there's a need for major improvement in environmental, socio-economic factors and healthcare facilities. There's a limited scope for precision medicine in sickle cell disease at the moment. There's a need for improved patient stratification, and at some level we should use what we've got, and we should increase the use of alpha globin genotyping. There are some validated genetic markers like for Gilbert syndrome, but we need to develop them, and we need to develop validated biomarkers and not just rely on non-validated, non-replicated studies. Newer emerging treatments are coming through, and there's better understanding of these treatments, and it may be possible to select more precisely with more stratification. And in the future, maybe there will be the use of multi-drug therapy, but in a way, precision medicine may become less relevant as curative treatments become widely available, as they probably will do, with initially more widespread safe stem cell transplantation, and in the distant future, in 10, 20 years, the widespread application of in vivo gene therapy to correct the HBS mutation, which is possibly where this will all end up. And then, obviously, once you have a curative treatment that works for everyone, you don't need to worry so much about being precise. I'd like to, lots of people are involved in this work, and these are the people I work with at King's College Hospital. John Stravoulis, who runs the research laboratory, and John Bruin did some of this work, the important work on the identifying the ApoE variants. Stefan Menzel, my colleague, identified the BCL11A as a determinant of hemoglobin F, which is now an important part of many treatment approaches. Thank you.
Thank you, Dr. David Rees, for that beautiful presentation. Enjoyed listening to you. Very different angle to the subject. I haven't heard this kind of stuff in past. So we have some of the Indian colleagues here who may like to interact with you, have some questions. So those who have questions, please open your videos and go ahead. Dr. Akanksha Garg.
Hello, sir. Thank you for the lovely talk. My question is regarding the co-inheritance of G6PD in patients with sickle cell disease. So should we be testing some of the patients, a particular subset of patients for G6PD deficiency as well? And how does it affect the clinical outcome in terms of the effect of sickle cell disease with the G6PD deficiency?
It's a very good question. We do test all the children at birth for G6PD deficiency, partly for the simple reason that we want to avoid them eating broad beans or taking drugs which are unsafe. And in our population, it's probably the same for you, about 5–10% are G6PD deficient. People have looked to see how it affects the clinical manifestations of sickle cell disease. You seem to be more anemic if you have G6PD, not due to chronic hemolysis, but the baseline hemoglobin is lower. And there's been a variable association with cerebrovascular disease. And there have been reports from some countries, from France in particular, saying that if you have G6PD deficiency, you're more likely to have a stroke. We looked and couldn't find that, and other people haven't found that same association. The confounding factor is that G6PD is a marker really for being male, and there are quite significant sex differences between how men and women do with every disease, but with sickle cell disease. So some of the associations are more to do with the fact that you're comparing men with women rather than G6PD with non-G6PD deficient. So I think it is relevant, and if it's possible, I think it's useful to test for it, because there are simple things you can do. In terms of how it affects sickle cell disease, it maybe has some effect, but it's not massive. It doesn't have a big effect.
Thank you.
Verma.
Sir, thank you, sir, for the nice talk. What is the frequency of TCD in your clinical practice? Like, do you do it annually, or like what is the frequency of monitoring transcranial Doppler?
We do it from the ages of 2 to 16. We do it once a year. if it's abnormal, we repeat it more often. That was what was done in the original STOP study. In fact, people have shown that after the age of 10, it almost never becomes abnormal. So that I think we probably could stop at the age of 10 fairly safely. Certainly when you're starting, although if someone's never had a TCD when they're 14, then it's still important to do it, if that makes sense. I think we do it in all the sickle cell children we see. The evidence is for SS and S beta 0 only, and there's no, but we found it easier to do SC and S beta plus as well. So, I mean, I think that's the simple recommendation. We found it took more time to pick out all the different types to say, oh, this person needs it, this doesn't, then it is quicker just to do everyone, and then you don't need to worry. Do you do TCDs, and do you do them for your patients? Or?
Yeah, but very infrequently, not that routinely. Yeah.
It is difficult. It's definitely true. It's important to concentrate on the young children, that the peak incidence of stroke is 2 to 5. And if you've got limited resource, then the key one is to do, under 5 really, and to focus on those. And, we develop with their indices. So if children are more anemic, they're more likely to get stroke as well. So if children have, low hemoglobins under 7, then there's a strong correlation between risk of stroke. And so you can try and target, the TCD on the more vulnerable population. But age is the key factor then, and definitely doing, 2 to 5 is the group to concentrate on. Although technically they're more difficult because they don't tolerate, they wriggle around and they don't like it. So the tendency is to just do it on the older teenagers who don't care. But I think the effort should be put into the younger children if possible.
Thank you.
Dr. Bhavna.
Good evening, sir, and thank you for that excellent talk covering all the relevant aspects of the advances in the sickle cell disease. I have 2 questions pertaining to alpha thalassemia. First one is, what are the clinical predictors to suspect co-inheritance of alpha thalassemia? Without looking at the CBC report, any clinical modifiers which make you suspect that the patient probably has co-inherited alpha thalassemia? And my second question is, as you said that with co-inheritance of thalassemia, it becomes a predictor for stroke or cerebrovascular disease. There's probably a higher incidence. So any such association or any such relationship with the ocular complications with proliferative or non-proliferative retinopathy, which you have observed?
That's, again, very good questions, really. In terms of, I don't think you can tell, unless there's a clear family history of alpha thalassemia, which there rarely is. I don't think you can tell clinically. I mean, the alpha 0 thalassemia, if there's a history of it's not very common. I don't think it's very common in India, and it's not very common in the UK, but if there's a history of recurrent miscarriages, that is maybe suggestive of possible family history of alpha thalassemia. Obviously, when you've done the full blood count, then you can get a pretty good idea by looking at the MCH, really, that they tend to have lower MCHs and higher hemoglobins. So without doing and we have done studies, if you use a cutoff of 27 for the MCH or something, you pick up, or 25, you can pick up most of those with alpha thalassemia. What I meant to say was that the risk of stroke is less if you've got alpha thalassemia. I think I don't know about retinopathy. There may be studies about it, which I don't know. My gut, I think it's the sort of thing that makes retinopathy more likely, in the sense that it makes the hemoglobin higher, and it tends to be people with higher hemoglobins that are more risk of retinopathy, for possibly to do with viscosity. So in SC, for example, retinopathy, as you know, I'm sure, is much more common. I have a feeling that in S with alpha thalassemia, it might be more of a problem, but I don't know that. I'm sorry. I'm sure there probably is a study done, but possibly not. And it would be a good question to ask.
Thank you, sir. Thank you.
Dr. Mukul.
Good evening, sir. Sir, my question is with respect to the treatment guidelines. With so much genetic variations and environmental factors, as well as the variants which are there in different parts of the world, how replicable are treatment guidelines from one part of the world to the other?
Yeah, it's a very good question. I think you're right. Exactly. If you're implying they're not useful, and I think you're right entirely. I think, sickle cell is a very environmental disease. There's genetic variability, but we know, I think everyone knows if you talk to patients, there's a whole number of genetic factors that determine it. And as I said in our study, even comparing Paris with London, which you'd think would be the same, or I would, there were quite significant differences. And so I think there's a core evidence for things like, penicillin's been one of the issues, whether it's that it's been shown in the States and Europe it's good, and whether it would be useful in Africa as well. And studies have suggested that the same spectrum of infections occur in Africa. So the feeling is, again, and I think the same people has been looked at in India as well. Hydroxyurea, again, there was obviously started in the States and Europe, but the big studies in Africa recently have shown very, very clear benefit in African patients. And again, there are some, I don't think randomized trials, but quite a lot of studies from India showing benefit in hydroxyurea. So I think the core treatments of things like penicillin and hydroxyurea probably are translatable from one population to the other. In terms of how you manage pain and what advice you give people to how they dress and what painkillers you use and whether you use IV fluids and oxygen, no one knows any of that. And I think those would vary very much depending on local facilities and guidelines. And in a way, you don't want, there's so much variability. You don't want to just ideally adopt. Most of the guidelines aren't very strongly evidence-based. The penicillin, hydroxyurea, TCD there's kind of good evidence for. But the evidence that TCD is useful in an Indian population, say, I don't think that study's been done. So it may not be applicable and useful in the same way.
Thank you, sir. Thank you.
Dr. Suman.
So your talk was very nice. I just wanted to know, are you doing alpha thalassemia screening in all the patients of sickle cell anemia, or in a patient who is not responding to hydroxyurea?
Well, no, we try to do it on everyone. We don't routinely do it on everyone. We have a set of blood tests that we do on everyone, which includes G6PD, that doesn't include alpha thal. I always try and request it, and I think we should probably make it a routine measurement when you first see people. As I said, it doesn't in fact alter your response to hydroxyurea. Some people have found that. When we looked, we didn't find that, but there are other studies suggesting that people with alpha thal respond less well to hydroxyurea. That's not what we found, but I think there are reasons for wanting to do it. Really, I think if nothing else, you try to give families prognostic advice, and I think you can be slightly more positive if they've inherited alpha thalassemia. They're less likely to get life and organ-threatening complications, at least in London. I would think that's almost certainly true in India as well, but I don't know.
Thank you. Thank you so much.
We just have a minute more, so very quick question from Dr. Radhika and then Dr. Ray.
Thank you, sir. That was a lovely presentation. Sir, I'm a hematologist. So all patients at diagnosis of SCD, we initiate the patient on a low dose hydroxyurea, 10 mg per kg body weight. So patients with high HbF level are less likely to develop symptoms and all. So do you recommend that we take a call on initiation of hydroxyurea based on the HbF level? What I mean to say is patients with high HbF level, 20 or 20%, maybe I don't need to really hurry and start them on hydroxyurea. What's your call on that, sir?
So again, they're so good questions, really. I think it's true that success to hemoglobin F would count. In the recent studies, so if your hemoglobin is above 9 or your F's above 20%, then that was counted as responding to hydroxyurea. I think there are probably added benefits to giving it to people even with those parameters, but it depends a bit on your resources in terms of availability of hydroxyurea and blood tests. And it's true that those people with higher hemoglobin F levels respond better to it. So that the ones who start with high F levels have a much more marked response, so we'll probably get more benefit. So I think if you're starting everyone on it, I wouldn't exclude those with high F levels. I think if you're in a situation where you can only give it to 20% of the patients, then I wouldn't, I would avoid those. I wouldn't give it to those patients. Does that make sense? So I think there are, although those people are mild, there probably are still benefits from making them even more mild. And paradoxically, like most medicines, the people who need it least are the ones who benefit most from it. And the people who have the milder disease are the ones who get the more marked increases in hemoglobin F.
Thank you. One last question has been put by Dr. Ray.
Thank you.
In the chat box. This is about thalidomide, whether thalidomide has any role in sickle beta thalassemia.
Well, thalidomide, I know in the UK, thalidomide is not popular in Europe, really. Pomalidomide has been looked at in sickle cell. In general, the feeling has been the side effects don't justify the benefits. So that's a European perspective. I know it's widely used in India in thalassemia, or that it is used. And it is interesting. I mean, I'm probably not the best person to answer that question. I think it would be good to do a randomized control study, really, if possible, and to see whether it's beneficial or not. I think in the European context, we could never do that, because thalidomide is not a drug anyone would ever take. So,
thank you, Dr. David Rees. You accepted our invitation, spared your valuable time, educated people from this part of the world. Excellent lecture and a fantastic question and answer session. Indeed.
Thank you for inviting me. It was very enjoyable.
Bye-bye.
Bye.
We'll move on to the second lecture of the day, and our second guest speaker is Dr. Shahram Kordasti from London. He is MSc, MD, PhD, senior lecturer and group leader in applied cancer immunopathology at King's College London, UK. Honorary clinical hematologist in Department of Hematology at Guy's Hospital, London, UK. Following graduation from medical school and clinical training in internal medicine hematology, Dr. Kordasti received his MSc in medical immunology and PhD in cancer immunology from King's College. He established the role of drugs in MDS and their effects on disease progression and the response to treatment. He continued his work at King's College London and developed an interest in immunobiology of aplastic anemia during this time. He has been senior lecturer at King's College and senior physician at Guy's Hospital since 2018, and he continues to study the immunobiology of myeloid malignancy and neoplasms. His main research interest is the plasticity of CD4 plus T cells, their interaction with inflammatory microenvironment, and their role in the immunobiology of myeloid malignancies. Computational biology, multidimensional cytometry, as well as multiomics data integration for patient stratification is another focus of his research group. His clinical interests are in aplastic anemia, myelodysplastic syndrome, and myeloproliferative neoplasm. Today he's going to lecture on understanding the immunome and responses to immunotherapy in MDS MPN. Over to you, sir.
Hi, can you hear me well?
Yes.
Okay, great. Thank you very much for inviting me, and hello to everyone. I bring up my slide. All right. So I hope you see my slides as well.
Yes.
Good. All right. So and thanks for the introduction. It makes life easier for me. I don't need to introduce myself. So I go straight to, I just have the laser pointer. I'm Shahram Kordasti from King's College London, and this is basically the talk I've recently done with some additions in our EHA annual Congress as an educational talk for hematologists regarding the role of immune system in MDS MPN, particularly on MDS. The main focus will be MDS. And what's next in terms of immunotherapy, what we know about immunotherapy, and what is next in terms of immunotherapy in myeloid malignancies, particularly in MDS. These are my disclosures, and none of them are relevant to today's talk. So I hope that by the end of my talk, we have a better understanding of the heterogeneity of immune response, excuse me, of immune response in MDS MPN, a better understanding of interaction between somatic mutations and immunome and its effects on the choice of immunotherapy we may have, and immunome as a necessary component for patient stratification. So immunotherapy really is a success story in some cancers. Really, when you talk about the advanced melanoma, that was a death sentence back a few years ago. Now we are talking about almost cure, and we're talking about combination therapy and getting progression-free survival in these patients at 12 months, basically around 50%, which is excellent. And we should remember how terrible was the outcome of these patients. Or, of course, this was a bit of hype in the news and got a bit of media attention. But I think we shouldn't forget this small cohort of patients, that 12 patients with locally advanced colon cancer, that they basically received immunotherapy and they didn't need chemo or surgical intervention. Rectal cancer, excuse me. So we have really good response in so many cancers, and that is encouraging. What about MDS? When we talk about MDS, sometimes we hear and discuss that, well, does immunotherapy work in MDS? And we shouldn't forget that the only curative therapy in MDS actually is a stem cell transplant. And we shouldn't forget that we, as hematologists, we are the pioneer in cell therapy and immunotherapy because stem cell transplant is a type of cell therapy and immunotherapy. And when we give DLI, actually we are reawakening the immune response and immune system in MDS, and it has a very clear effect in these patients. So yes, immune intervention and reinstating the immune response in MDS is a very promising is important. But what is a bit unusual about MDS is, at the same time, sometimes in a group of these patients, you need to modify immune response. Some patients respond to ATG, which is quite surprising, perhaps, in these patients, and see how come that we need to give immunosuppressive in one group of patients, or give lenalidomide or other immunomodulatory drugs to modify the immune response. Whereas in the others, you need to give something like DLI to induce graft versus leukemia effect. Why this happened? What's going on? And the other aspect we should remember is that there are other medications that are not necessarily immunomodulatory by definition, but they do have immunomodulatory effect. For instance, hypomethylating agent, if you talk about 5-azacitidine, for instance, which is the base for a lot of treatments in regimens in MDS, they do have some effect on immune system. It's controversial. I agree that some people find different things about the effect of hypomethylating agents and the immune system, but in any case, there is no doubt that they have some immunomodulatory effect. So we need to remember we already playing with immune system in MDS with some promising effects. And that is already happening. But there are so many other things that are ongoing. There are a lot of studies at the moment. And this list is not particularly up to date. It's perhaps, it was from 2021, if I'm not wrong, when we wrote this review, that we looked at the all the different types of immunotherapy techniques that we have, from checkpoint inhibitors to adoptive cell therapy to vaccines to cytokines, etc., they all, almost all of them, being used in MDS. And if you look at the list of these trials, that again is not up to date, but you can see that several different types of immunotherapies are being tried in MDS AML. So we are trying this. Nevertheless, it's not that promising when you look at some of the data. It's not very encouraging. Look at these data on checkpoint blockade. You can see the response really is varied, and 13%, 7%, not really what you expect, and not much improvement in survival. And what is really makes us kind of, at least I get very nervous when I look at these numbers, is that we don't know who are those 26% who have a bit of response. What defined them? What are the factors that based on that we can decide patient A is more likely to respond compared to patient B? We have very little knowledge about that. And some of the data are disappointing. So if you focus on combination therapy, for instance, this is a recent publication that they look at the combination of check inhibitors, immune check inhibitor and AZA, really not much benefit in MDS. So in one hand, we do have strategies that when you modify immune system, you get very good results. On the other hand, more novel approaches like checkpoint inhibitors were not that successful as yet in MDS. And why is that? Why there isn't a significant breakthrough with immunotherapy in MDS MPN? There are several factors, perhaps, and the answer is not very straightforward. But what we know is, first of all, the heterogeneity of the immune response. Are we talking about one disease? If we are talking about a disease that in one hand they respond to ATG, and in other hand they respond to DLI or stem cell transplant and kind of resetting the immune system, are we talking about really one disease? How heterogeneous this disease is? The other aspect is the non-classical microenvironment of MDS, which I will explain a bit more. And mutational burden and immunogenicity of the mutation. That's another aspect that we should always keep in mind. In MDS, we are not talking about immune response. We're not just talking about immune system. We are talking about another very important factor, which is the somatic mutations that goes hand in hand with immune response. And these two needs to be looked at the same time in the context of microenvironment. And that's when you can have a better understanding of what's going on in MDS and how you can target it. If I want to really summarize the MDS pathophysiology, very simplified as kind of cartoon or very simplified version of pathophysiology of MDS. Obviously, environmental factors, somatic mutation, genetic background, and inflammation, they are the four major players in pathophysiology of MDS. I'm going to start with inflammation and malignant clone interaction and see what we know about it and how it affects the disease behavior. By now, we know very well that NLRP3 inflammasome pathway, it's a key factor in chronic inflammation that contributes in MDS pathophysiology. that it's basically a vicious circle of inflammation, cell death, and more inflammation that continuously contributes to a inflammatory related cell death and genomic instability. And that is something that it's now very well known. But and also in MPN, although the contributing factors are different, but we very well know that inflammatory pathway activation is again in MPN has more or less the same effect. So myeloid-derived inflammation, both in MDS and MPN, it's a backbone or the basis for the disease progression, and that's what makes MPN clone or MDS clone to go to survive, to give them advantage, and that's a crucial aspect of both diseases. Although they are different, although even the types of inflammation are different, considering the very clear basically pathway activation and JAK2 pathway activation, and that's quite different with MDS. But the end result is the myeloid-derived inflammation. But there is a big but, and that is when we talk about inflammation, we need to be clear what types of inflammation and what types of immune response we are talking about. MDS, like any other diseases in human, at least, you have mixed pattern diseases. It's not really very clear-cut, purely autoinflammation that damp and neutrophil and myeloid-derived inflammation involved, and not clearly autoimmune type that you have self-antigen T and B cell involvement. Majority of diseases are sitting somewhere closer to this end or that end, and basically they have a mixed pattern. MDS is not an exception. So it has elements of autoinflammatory, as I've mentioned, and elements of autoimmune disease. Now, and if we focus here, basically what happens is that either you have patients that are, for instance, MPN is closer to the autoinflammatory part of or spectrum of the disease. You have MDS patients that they are more inflammatory subtype, and they are closer to this end. If I want to give an example, for instance, Sweet syndrome and MDS, or VEXAS, that they have inflammatory component on the autoinflammatory, and MPN is very much autoinflammatory. And you have MDS with components of autoimmunity. And these MDS patients, there are two aspects, and again, we need to think and we need to distinguish this. One is the presence of autoimmunity, and MDS patients that they have element of autoimmunity as part of their pathophysiology. To explain a bit more, presence of autoimmune diseases, that's the study done by Karolinska a few years ago, and they looked at thousands of patients with MDS and AML and compared those with, if I'm not wrong, 44,000 age-matched healthy controls. And they identified a few factors that contribute to AML-MDS. One is presence of autoimmunity, and second was chronic infection. And these combination of these two contribute to MDS and AML. So presence of autoimmune conditions correlate with higher risk of MDS and AML. That's one aspect. The other aspect is some types of MDS, they are closer to the autoimmune subtype. Perhaps the best example we can give is hypoplastic MDS. You may ask, what is hypoplastic MDS? How you define hypoplastic MDS? How different is from aplastic anemia? I'm not going to go there. These are all valid questions, And I agree with you that definition of hyperplastic MDS is not very clear. But anyway, whatever we consider autoimmune MDS, that's what we mean. So the MDS with more of the autoimmune components within that. And those are the patients that respond to immunosuppression. And of course, aplastic anemia that within is obviously is a completely different category of diseases, but in terms of it's not non-malignant, but it's closest to autoimmune diseases. And although it's not a classic autoimmune disease, but immune aplastic anemia considered the closest to autoimmune diseases. So first point, I hope I made it more or less clear that we should remember we are talking about a heterogeneous disease, and this heterogeneous disease has heterogeneous immune response. And patient A versus patient B, they have different profile of immune dysregulation. Could be autoimmunity, could be autoinflammatory, or somewhere in between. But inflammation is almost always a necessity for the MDS and MPN for survival of the malignant clone and for the continuation of the disease, to give survival, to give advantage to malignant clones. But this inflammation is not always bad. Remember that we need inflammation for a effective immune response against malignant cells. So immunogenic cell death could lead to activation of T cells, and then you have antigen-specific T cells that kill these malignant cells. And that is necessary. But in longer term, so we should remember that inflammation and time, they make a huge difference. So in longer term, inflammation changes its nature. It becomes something different. And what we call it, maybe it's not as severe or as active as it is here. It becomes less pronounced, if you like. And we call it basically smoldering inflammation, an inflammation that it's not very clear-cut or very clear-cut and very severe, but at the same time, it's there. And it drags on and feed the malignant cells. And in longer term, it has other effects. It reshapes the microenvironment. This is a very nice paper published a couple of months ago, or maybe less, in Clinical Cancer Research by Kordasti. And basically, they have shown that this chronic inflammation reshape the mesenchymal stromal cells, or MSCs, and make them to expand regulatory T cells. And that regulatory T cells inhibit the effector T cells, and therefore we don't have a good response against malignant clone anymore. And that mediated by interferon gamma that comes from myeloblast. So we should remember, basically, we have inflammation. This inflammation is not always bad. Second is, in longer term, inflammation has different effects compared to longer term. And so between shorter term and longer term, there are differences. And if you want to treat these patients, it's important what you want to target and when. And that's important. Targeting immune system is different here compared to here. So I just summarized that. So at earlier stage, we have an effective immune response against malignant clone immunogenic cell death, which is important, and it leads to expansion of very active T cell response, which targets stem progenitor cells. And you don't have that many mechanisms to control this immune response. But as the disease progresses, different cells like MDSCs, myeloid-derived suppressor cells, regulatory T cells, they are expanding, plus MSCs, as I explained, and they inhibit the an effective immune response, and you don't have that effective immune response anymore. Plus, these cells become kind of exhausted, increase the expression of immune checkpoints, etc. And that's what we call immune subversion. Is it specific to MDS? No, that's seen in other cancers as well. And these regulatory T cells, you can see this is just some of the data we have from bone marrow using sort of imaging. You can see the Tregs, FOXP3 positive Tregs, several of them in the bone marrow compared to a healthy bone marrow. And also seems like these cells are closer. So if you calculate the distance between Tregs and progenitor cells, and you can see in patients you have closer, basically the distance is far less, which makes a difference. And there are suggestions that Tregs play a role as a niche for the malignant cells, which is different from their role as an immunosuppressive cells. They are actually provide niche for malignant clones. The other difference which I explain is that the microenvironment. When we talk about solid tumors, we're talking about an environment which is confined. You have a closed environment. Cells cannot easily go inside. You don't have the accessibility of the cells. You have extracellular matrix, you have fibroblasts, you have a very closed environment. And that is basically, you have an environment that you have T cells that are antigen specific, but they are basically completely controlled and inhibited. Whereas in bone marrow, you have accessibility of malignant clone. And that, so here you have clones that are immunogenic, but they cannot be eliminated because the environment is so suppressive that T cells cannot eliminate these clones. But in the bone marrow, these clones are all exposed. So by the time we have the malignancy, the most immunogenic clones have already been eliminated. And the other thing is these tumor infiltrating lymphocytes are, we don't have them in bone marrow because basically the T cells are come and go. Some of them remain in the bone marrow, but they don't have that classic tumor infiltrating lymphocyte, which are very much, usually, they are very much antigen specific. And if you give something like checkpoint blockade or etc., you can reactivate them and they recognize immune cells, tumor cells. So these are the microenvironmental change. So although the immune subversion, the inflammatory component, the autoimmune components, they are not that different from other cancers, but the microenvironment is quite different in bone marrow. The other aspect is the contribution of somatic mutation. We know several somatic mutations are now can be detected in MDS, and they have different prognostic effect. And you have seen a couple of weeks ago, or maybe a month ago, published the new IPSSM, which is basically the prognosis for MDS is based on the somatic mutation as well. So they have different effect on the patient's outcome. But they also have effect on the immune system. For instance, U2AF1, it's the one that induce pyroptosis, induce myeloid-derived inflammation. On the other hand, we and others, we have shown that basically SF3B1 is the one that it's not that related to NLRP3 activation and inflammation. So in one hand, you have the one that is U2AF1, very much pro-inflammatory. The other one is not that pro-inflammatory. You have those other ones that you can find somatic mutation and predict basically neoantigen related to this somatic mutation and use them as cell therapy or vaccine therapy. And there are clinical trials ongoing. Or you have somatic mutations that, like TP53, that they induce exhaustion of T cells and expansion of Tregs. And that is another type of somatic mutation. So if I want to summarize, you have somatic mutations in MDS. Some of them are pro-inflammatory, some of them are anti-inflammatory, some immunogenic, some immunosuppressive, and perhaps some of them that we still don't know what's their role and what's their interaction with the immune system, or maybe they are immune neutral. So somatic mutations also have different effects and interaction with immune system. So if I now we talk about immune subversion, but you need to see immune subversion. Sorry, are you asking question? Sorry.
No, go ahead.
I think I am. Oh, sorry, I apologize. It was my fault. Sorry, I thought somebody was asking questions. So if I summarize the first part of my question, my talk is, basically, we have genetic background, environmental factor, age and inflammation, somatic mutation, chronic systemic inflammation, infection, etc., that contributes to an ongoing inflammation, pyroptosis, and immunogenic cell death, and basically lead to myeloid bias and basically provide a very good environment that if you have the right mutation, it leads to genetic instability and selection of somatic mutation. And then when you pass that threshold and enter the malignant phase, basically you have this smoldering inflammation that drives the malignant clone, add to genetic instability, you have additional mutation, and that's ongoing. So you may agree or disagree with this, but there are studies that I'm sure you've seen published a few years ago that they think that early initial mutations or early initiating mutations like the NMT3A, TEP2, ASXL1, and then the more subsequent one like FLIC3, etc., that they make the situation worse and contribute in transformation. And at the same time, the immune subversion happens, as I've explained a bit earlier. The main thing here is, and that's something that we should always remember, is that this transformation and this smoldering inflammation is something that drives and helps, but doesn't necessarily mean that if you don't have inflammation, that's not happening, but definitely contributes. And the other aspect that it's still not clear, and lots of groups are working on, is where the chip patients are sitting. Is the chip here, or actually when we talk about the initial disease, we are already here and we have chip. So that's ongoing study by several groups. So I hope I convinced you that the disease itself is heterogeneous in terms of genetic, in terms of immune system, in terms of response to therapy, and it follows a stepwise transformation. Having that, it means that therefore we need a more comprehensive approach for patient stratification. You cannot just rely on somatic mutation or immunome or specific biomarkers and say, okay, this is what we want. really we do need a more comprehensive combining somatic mutation, inflammatory pathway, doing deep immunophenotyping, look at the microbiome, look at the bone marrow niche, and have an integrative immune score to be able to better stratify these patients. And do we have any example? I'm going to give you some unpublished data as an example from my own group that we are working, for instance, on SF3B1 mutated patients to see whether looking at gene expression and immune deep phenotyping, can we classify patients and identify them based on their immune response. So we had about 28 patients, 18 with mutation, 10 without, and look at the difference. There are not many differences. Obviously, they have more ring sideroblasts, but generally they are more or less comparable. And we wanted to see whether we can identify SF3B1 mutated MDS subtype based on their immune signature. Do we have an immune signature that identifies SF3B1? And to do that, first we did the somatic mutation profile, and this is, you can see there are, of course, other mutations, but the group that with SF3B1 mutation, they all have it. And then we used both flow cytometry and mass cytometry data. We did data cleanup and transform the data and use a pipeline called T-Rex to identify phenotypically different group of patients. And that is basically tells you what are the differences. So red is one group, blue one group, and identify patients automatically and put them on different groups. And in addition that, we rely on another approach called marker enrichment modeling, that it's rely on rather than having the level of expression, it relies on the interquartile range of expression of markers. So with the same median expression, you may have a smaller or larger interquartile range, and basically the smaller interquartile range means that you are more enriched. What's the use of this? If I want to explain is, when you define cell population, for instance, you say NK cells, you say they are CD16 positive or CD47 positive or CD56 positive, but we don't have how positive or negative these cells are, and can we identify if the expression changes, what is the number? And this is an example, for instance, that you can, based on marker enrichment, you quantify between -10 to +10 how positive or negative cells are based on different markers, +3, +4, +6. So you can give a number, and based on that, see how they are changing and how you can identify group of cells that are different between the two groups of patients. And you can see here, using this approach for SF3B1 mutated patients, with 95% specificity, we managed to identify. So we mixed all these patients together and we ran through this pipeline to tell us which one is mutated, which one is wild type. And you can see with 95% specificity, we identified those patients in the bone marrow based on their bone marrow cells that are mutated or non-mutated. And what was very important and interesting was that they had a myeloid cluster which is less activated compared to mutated one. And so basically, this is another panel, more or less give us the same results. And you can see that HLA-DR low monocyte was the marker that confirmed the main determinant for mutated, non-mutated. And same in the peripheral blood. And now it's ongoing. Now we are looking at monocyte, NK cell, gamma delta T cell, CD4, CD8. So the whole signature is now being investigated. And looking at this, you can tell that how distinct the immune signature of these two groups are, and that could help us to identify what is the immune signature of SF3B1 mutated patients, for instance. And then the next question that we are now working on is whether they are less responsive to external stimulation, for instance, LPS, that it's for TLR4 activation, and the pathway which is IL-1 beta IL-18, very much the pathway that is inflammasome related, and same as MDS. Are they less responsive? And it seems like that this is ongoing, but it seems like LPS is not an important factor. IL-1 beta is the one. So it seems like autocrine activation is the main activation pathway for these patients, for these cells. And now we are trying to understand how this is changing in SF3B1 mutated cells. So I finish with two summaries. Number one, again, I hope I convinced you that from low risk to high risk MDS and AML, we are changing from a pro-inflammatory to immunosuppressive environment, and we go through a tumor escape pathway that is a stepwise and includes several different immune dysregulation factors. And what is clinically important, and I hope I made it clear what I mean by that, is that MDS patient, we need to have an approach that includes several clinical and multi-omics data approach and computational methods to identify different subtypes of these patients. And that is clinically important because those patients with autoinflammatory subtype, you may target inflammasome, TLR pathway, S100A9 pathway, and treat them, rather than going based on IPSSR or similar approaches. Those patients with autoimmune profile, how to target those and give them immunosuppression. Those that they have immunogenic somatic mutation, and therefore you can use those as a vaccination or target them and give them a combination of checkpoint inhibitors and vaccination. And those that they have nothing to do with the immune system, patients that passed that stage, and there is nothing we could do, and we need to rely on transplant or hypomethylating agent, etc. So therefore, we have a better approach to identify patients which are likely to respond. And therefore, I'm hoping that we have also an IPSS-I or IPSS immunome as the next step in MDS, or IPSS-IN maybe, to have a better definition of these patients for therapy. And this is the final slide. Inflammation is not necessarily bad, but we need to find the right immune intervention in MDS, right target and right time to preserve a healthy immune surveillance and control inflammation. If we don't do that, it's useless. So I hope I delivered this message, and we are not there yet. And this is my group. That's all the people, bioinformatician and also computational biologists working on this, and wet lab people, collaborators around Europe and States, and funding bodies that are supporting our work.
Dr. Kordasti is, I think, frozen. assume he will log in again and come back to us. We'll just wait for him to get back to us. Meanwhile, if you have questions, please put up your hand raise sign. He should join us soon. Yeah, here it is.
Hello, I apologize. For some reason, my computer suddenly switched off when I said the last word. Apologize.
We realize that. So there are some colleagues here who would like to interact with you. Dr. Sharma, Dr. Verma, your question.
Thank you, sir, for nice presentation. So, like in MDS, if this is so much inflammation going on, do you think that there should be effect of steroids having some clinical response in the form of maybe rise of hemoglobin and improvement in cytopenia? So
yeah, very good question. Very good question. It's I get this question all the time, and I think it's a very valid question because you say, okay, if you have inflammation, if you have this, all these things are going on, why are we not giving a steroid to these patients? There are two aspects. Number one is when we talk about a steroid, for instance, prednisolone, if we give this to this patient, we have a blanket suppression of everything. So first of all, steroids are not that good on controlling myeloid-derived inflammation. So actually, most likely you suppress the most effective and helpful inflammation, which is cellular response against malignant clone, rather than controlling that smoldering inflammation. That is not that good, number one. And number two is for how long you're going to give it. It's not something that if you're going high dose, basically a blanket suppression, which in a patient that are really old, usually old, you may actually contribute to additional side effects, etc. So I don't think a steroid is a good approach. But if you mean, for instance, giving TLR antagonist to control the myeloid-derived inflammation, plus checkpoint inhibitors or something that controls to reinstate the immune system, I think that is the approach we need to consider on those patients.
Thank you, sir. One more clinical scenario I just wanted to discuss. So we had one young male, 25 years old, who was diagnosed as acute myeloid leukemia 3 months ago, and it was flow proven. He had 30% blasts in the bone marrow presented with cytopenias. But somehow after workup, he could not, afford the treatment, and he was lost to follow-up. He didn't take any alternative medicine or any other medicines except the supportive care which we give in the form of antibiotics and antifungals. But after 3 months, he presented to us in the previous OPD day before, and he has normal hemoglobin, normal counts, platelets, everything is normal. We double checked it with the peripheral blood examination, and there are no blasts in peripheral smears. So, do you see such cases, or how will you explain whether there is some, upregulation of Tregs or something like that, which is maybe the pathophysiology behind this, where patient has spontaneous, resolution of disease, maybe transient, but this is the current scenario of that patient.
Yeah, it's very interesting case. Obviously, I didn't have such a patient because. We never had such an experience with the patient. But if I have an educated, so the answer is I don't know. But if I want to have an educated guess, is I've mentioned about immunogenic cell death. And if I'm right, you said that it was cytopenia, correct?
Yeah, he presented with anemia.
And the bone marrow was, how was the bone marrow packed?
Yeah, it was 30% blasts.
Yeah. Whether an immunogenic cell death happened, that because you have a lot of cell death,
Yeah.
And if in the right environment, inducing by chance an effective immune surveillance, that's the only thing I can think right now. Obviously, I don't have any evidence, but that's my educated guess. But this is an extremely important and interesting case, because if it's the case and that person has that effective immune response, it's a very, very interesting case. So I recommend that you report this case, and then perhaps can be investigated further to see what's the mechanism. That's my guess. Obviously, I might be wrong.
Thank you. Thank you.
Thank you. Dr. Sushil?
So I just wanted to ask, I noticed that very interesting and engaging talk, Dr. Shahram. My specific question was regarding the microbiome that you had mentioned. What could you just give me like a feel of what you are finding when in terms of microbiome? Is it the diversity issue, or is it a particular organism ratio that is impacting your the translation into an MDS? I'm just curious to know what in the microbiome you were finding.
Yeah. Again, okay, that's an ongoing work, and we haven't reached a definite conclusion. And the reason, let me explain what is the problem. The problem is we are talking about patients that are routinely receive antibiotic because they are neutropenic, and some of them, and they receive antibiotic. They're coming from different ethnic background. In London, we have from almost every place in the world. So they're coming from ethnic background, diverse ethnic background. They coming from, they have different diets. They have different level of oral health. So all of these factors. So to have a homogeneous group of patients that they have, they can be compared to age-matched controls, we had a lot of difficulty. So what we are doing at the moment is we send patients for oral hygiene. We make sure they, for 2 months, they are not on antibiotics. We try to have kind of same ethnic background, and we look at the oral and the stool microbiome in this group. And now we are collecting, because otherwise it's not comparable. And we are hoping to get the result in a couple of months, because now we collected enough samples to analyze. So I don't have answer to your question yet, because that's ongoing. There are, as you know, there are a few papers already published about the microbiome transplant and all the rest of it. There are several factors that are involved. My always worry about these studies is how homogeneous the cases are, how clearly screened for antibiotics, for diets. Because again, another thing is when I say we are closely work with a group that they are microbiome specialists, and they design a application that we ask patients to install on their phone, and they take pictures from their food for a period of 2 months. And then within that 2 months, they classify the food classes. They have several different classes. And again, they correlate with that. So it's so many things there. But the bottom line is, based on these classes, I think the diversity is more important than one pathogen. The diversity that leads to inflammatory related signature. And if you can find that inflammatory related signature, I think that can be used as a diagnostic test for some patients, of that if they have it or not. But sure. That's the way.
Thank you.
Thank you.
Pleasure.
Take one question from the audience. Have you come across any cases of MDS associated with Wax's syndrome?
Well, that's a very hot topic at the moment. Yes, of course, since the vexes described, we had a pool of patients that coming with vexes and MDS, but now, because whoever was now is diagnosed, you don't see that many. But yes, definitely there is a correlation. But it's not just vexes, it's CAPS as well, CAPS syndrome and MDS also. So it seems like when you have the inflammatory myeloid-derived inflammation, perhaps the MDS is definitely more common, or at least you have a subset of MDS related to inflammation.
Thank you. Dr. Roshni, your question.
For that excellent talk. With the COVID pandemic, would viruses like COVID also have an impact on the incidence of myelodysplastic syndrome in the future?
Very good question. I don't know that. Look at it. Question. Again, this is my educated guess. If you are talking about acute cases, that's likely. But if you are talking about long COVID and longer term inflammation related to COVID, whether it has an effect on MDS, I think we are early days. We don't know yet. But very well, I mean, that's something definitely needs to look at. We need to look at it. It's possible, but I don't have answer, obviously.
And the second question is, how do vaccines actually work? I mean, how are people actually working? Because one needs to have a right balance between inflammation, too much and too little.
Yeah. With vaccine, there are two aspects. How effective the vaccines are. We published 3-4 papers from others. We looked at MDS, MPN, myeloid malignancies, even on treatment. The response is not as great, obviously, as healthy donor, but they do respond. With additional doses, the coverage was very good. The worst cases were the patients with lymphoid and post-transplant, obviously. But in longer term, again, obviously we don't know, but I don't think in the very short period of time that we are having this vaccine, at least again, this is based on our evidence of patients we see. Anything suspicious as.
Thank you. I think we are running out of time. So Dr. Shahram, thank you very much for being with us. You accepted our invitation and enriched us with very new concept about this topic that you covered today. Thank you so much.
Thank you. Thanks for the invitation. And sorry for the technical issue I had.
Oh, that happens. Okay.
Thank you. Bye.
Bye. We'll move on to the next lecture, and it's my pleasure to introduce our next guest speaker. She has been to Mumbai, she has been to India, and she has been giving lecture to us through webs. And I'm grateful to her for all the education she has imparted. Dr. Haifa Kathrin Ali from Germany. To introduce her, she's professor, Department of Hematology and Medical Oncology at the University Hospital of Halle, Germany. Her main clinical research interests are in myeloid malignancies, MPN, AML, and MDS, and the allo transplants. She has several presentations at international congresses like ASH and EHA. Research articles have been published in journals such as NEJM, Blood, and Leukemia. She's going to speak to us on what's new in the management of myeloproliferative neoplasms in 2022. So over to her.
So good day, everybody. It's really a great honor to me to meet you personally and to meet all the friends and colleagues from India and elsewhere. And it is really my pleasure to just discuss a few new things which are relevant for everyday clinical practice in the field of MPN. I don't know, should I share my own presentation?
Yes, please.
Yes. Yes. So I hope you all could see it.
Yes.
Yes, I would like to start. Yeah. This is the title, What is New in the Treatment of MPNs in 2022? These are my disclosures. Well, I would like to start with ET And you know, there is not that much in ET, but I just wanted to draw your attention to the new NCCN guidelines that were published this year, because I think there are two things that are quite important for us to remember when considering treating patients with ET. First of all, unlike PV, ET is now divided into 4 groups, not just simply low risk and high risk, but we have a new category called the very low risk. Who are these patients? These are actually the younger ones, patients without a history of thrombotic events, and patients who are non-JAK2 mutated, making up around 30 to 40% of ET patients actually. And these patients have a very good prognosis, and that's why they are very low risk. And in addition, we have the usual low-risk patients. These are again the younger ones without thrombotic events, but who are JAK2 mutated. And in both cases, I think we all agree that we only need watch and wait because of the very good prognosis in these patients. And if they do have microvascular disturbances and symptoms related to that, then aspirin, I think, is a very good choice in the majority of these patients. Still, we know, and I think this is again very important, that despite the fact that we do have very low and low risk patients, this is in terms of, you know, progression, in terms of survival, in terms of transformation, but it is not in terms of symptoms. And I think Ruben Mesa and his group has taught us in the last 10 years very well that even these patients with almost normal blood counts could have severe symptoms. So I think we should pay attention to symptoms, even in these patients with very low risk and low risk ET. And automatically, this new classification brings us to the new question. Should we really, like PV, you know, the risks in PV is the age above 60 and or the history of a thrombotic event. Does this apply today also to patients with ET, meaning if I have a patient that got 60 years old, is this an automatically high-risk patient? And must I start with cytoreductive therapy? The answer is no. If you could look at the NCCN guidelines, published, as I said, this year, we have a new category, the so-called intermediate risk. These are the patients who do not have any thrombotic event, who are above the age of 60, but again are non-JAK2 mutated. This group of patients is actually also a group of patients doing very well, and where the evidence is lacking that if we give these patients cytoreductive therapy just because of the age, they will not really benefit from that. So in summary, we have the very low risk, we have the low risk, and we have the elderly intermediate risk that are non-mutated. All these patients do very well. And again, watch and wait, or aspirin in case of microvascular disturbance related symptoms is more than adequate. So the question is, for whom, for what ET patient should I start cytoreductive therapy? I think the indications are quite easy. The remaining group are those with high risk. These are the patients who are JAK2 mutated and elderly above the age of 60, or any patient with ET with a history of a thrombotic event. And sure, we will consider cytoreductive therapy if these patients develop complications like bleedings because of the acquired von Willebrand disease, because of thrombotic events, or progressive constitutional symptoms. And as we said, the microvascular disturbances if they don't respond to aspirin. So there is only a small group of patients we need automatically consider for cytoreductive therapy in ET, and not just take the age as a factor to start cytoreductive therapy. And in case we need cytoreductive therapy, I think the 3 classical medications, hydroxyurea, anagrelide, and interferon, are well known. And I just wanted again to highlight 2 small aspects. You know, if you have a patient with ET and this patient had a thrombotic event, then the question is anagrelide, if I consider treating this patient with anagrelide, as effective as hydroxyurea in preventing a second thrombotic event? And I think some of us are not aware of the answer, although we have a very nice randomized publication almost 10 years ago that shows very clearly that yes, we could use anagrelide in patients with previous thrombotic events in ET, and the effectiveness and the efficacy of preventing a second thrombotic event is comparable to that of hydroxyurea. So we're not doing anything wrong if you use anagrelide in these patients for one reason or another. And the second issue is interferon. You know, we have data of interferon in ET for almost 20 years, but we still do not have an approval. And, you know, because, you know, all the generica and, you know, no company is really interested in making a phase 3 trial in patients with ET. And that's why we don't have an approval, although I myself personally love interferon in ET patients, particularly younger patients. And we all know the data. But nevertheless, you know, if we look and compare between interferon alpha, ruxolitinib, and hydroxyurea or anagrelide as conventional treatment in patients with ET, again, we see that we have the best hematologic responses in terms of platelets, in terms of a white blood cell count, in terms of complete hematological remission in patients treated with interferon alpha. And we know that we again have the options and the potential of inducing molecular remissions, particularly in JEC2 mutated patients, with a possible positive effect on the natural course of the disease. But hope dies last. And finally, we do have a randomized clinical trial in patients with ET that is now testing ROPEC interferon, you know, Besremi, compared to anagrelide in patients with ET, so that someday we might get real good data and an approval so that we could use it on a wider scale. Actually, with this, I am finished with ET and I will jump to PV. Again, in PV, unlike ET, we still have this definition, high risk, low risk, based mainly on a previous thrombotic event and age above 60. If one of these two factors is present, then the patient is automatically, like the patient I just brought here, considered as high risk. And I think we all agree that treatment for these patients, again, based on the NCCN guidelines, there is nothing new, that we give these patients, in addition to aspirin. All patients, low risk or high risk with PV, need aspirin and phlebotomy to keep the hematocrit below 45. But if they are high risk, again, age above 60 or a previous thrombotic event, then cytoreduction is indicated and first line remains hydroxyurea. And that's what we did with the patient, and everything went well for years. I just want again to draw your attention to cardiovascular risk factors, as they are now mentioned quite clearly in all the guidelines. And we know very well, most of PV patients, at least in Europe and the United States, are elderly. I know that in India, the patients are much younger. Nevertheless, the presence of a cardiovascular risk factor, which is not that seldom, like hypertension or diabetes, and if it is present in a patient with PV, then the additional risk factor, this is a real additional risk factor for thrombotic events and for a bad outcome in terms of survival. And the more risk factors we have, the less likely the prognosis is going to be good. So I think nowadays we are very much paying a lot of attention to try to correct cardiovascular risk factors in these patients, in addition to phlebotomy and aspirin. And then we always have this issue, hydroxyurea resistance. And you know, sometimes the criteria are not that clear. I just wanted very rapidly, based on the example of my patient, to show you that it is actually quite easy using the ELN modified criteria to identify those patients who are really hydroxyurea resistant. And these are the patients likely to have symptoms, patients who are going to develop thrombotic events. So as you can see in our patient, 5 years later, under hydroxyurea and phlebotomy, he started to have symptoms and his white blood cells were rising. So the first criterion, I think we all agree that if a patient is on hydroxyurea and gets a thrombotic event or bleeding, then this is clearly a patient who is hydroxyurea resistant. And we know from the data, again, from Ruben Mesa, these are not new data, that despite our treatments with phlebotomy and hydroxyurea, still we have thrombotic events in every 4th patient we are seeing. So this is an issue. And if we were already using hydroxyurea and we had a thrombotic event, then the patient is clearly a case of hydroxyurea resistant. Second is frequent phlebotomies to keep the hematocrit below 45. You know, the Spanish group has shown that more than 3 phlebotomies per year is a group of patients associated with a bad prognosis in terms of increased thrombotic events. Well, we could discuss this if really 3 phlebotomies, per year is too much. But I think the idea behind this, if you have a patient with hydroxyurea and despite that the patient requires a lot of phlebotomies, then this is really identifying a subgroup of patients with PV that have biologically aggressive disease and are more likely to develop thrombotic events or complications related to PV, and to consider a change of treatment in this small group of PV patients. I think symptoms, again, thanks to the group of Ruben Mesa, we all learned that patients with PV do have a lot of symptoms, and this was the case in our patient, in my patient. It is not just the classical pruritus, but you all know very well that these patients might have a wide variety of non-specific symptoms. We now could semi-quantitatively measure using the total symptom square questionnaire. So symptoms, I think, is a very important issue in such chronic disease. The second factor, which is very important, is the hematological white blood cell increasing above 15,000. You know, PV is not just a hematocrit, but it is again platelets which do not play a role unless they are above 1 million, where actually the risk of bleeding is increasing because of the acquired von Willebrand disease. But increasing white blood cell count, particularly more than 15,000, has been clearly shown in the ECLAP trial to be associated with an increased risk of thrombosis. So I think the white blood cell count should be looked at. And indeed, if we look at the survival of patients of PV, in addition to the age and the history of a thrombosis, white blood cell counts is a very important factor associated with reduced survival in patients with PV. Okay, and then just to finalize the criteria, massive splenomegaly not responsive to hydroxyurea, but I think we all agree that massive splenomegaly in pure PV is quite rare. And if a patient with PV develops progressive splenomegaly, then I think that most of these patients are transforming to secondary myelofibrosis. And I think just look at the differential, and we will see very clearly that most of these patients will develop a leukoerythroblastic blood picture. So what alternatives do we have for these patients, like our patient, when they are identified as being hydroxyurea resistant? I think you all are very well aware about the 2 main therapeutic options we have. One of them is interferon, which has been now approved even as first-line treatment for patients with symptoms in PV. And, you know, the approved variety is, at least in Europe and the United States, is the Ropec interferon, Besremi, based on the phase 3 trial, the PROUD PV trial, and the continuation PV trial, where it has been clearly shown that the use of interferon is associated with good hematological responses and with a lot of molecular responses in terms of a reduction of the allele burden of the JAK2 gene. Yet we don't know what this means in terms of thrombosis or in terms of survival. So we still have to learn. And at the last EHA, actually the 6-year follow-up data of the PROUD PV and continuation trial were presented, where again we could see that the response in the majority of patients on Ropec interferon is maintained, and the allele burden is reduced, as I told you, in around 20% of the patients. And what is most important, I think, is that the incidence of PV risk events, meaning transformation to AML, transformation to myelofibrosis, or progression to thrombotic events, they are significantly less in the Ropec interferon compared to hydroxyurea. So I think now we have good data with a reasonable follow-up showing that in the majority of patients, we do have sustained responses. And what is very interesting, particularly for younger patients, if we get these molecular remissions and if they are sustained, is there a chance to have a treatment-free remission similar to that what we have learned from CML. And indeed, the French group has shown us at ASH 2020 some data showing that if a patient has long-lasting complete hematological remission for at least 2 to 3 years, or an allele burden of less than 10%, the majority of these patients would sustain after discontinuation of interferon their molecular remission. And if they relapse, we could restart interferon without the risk of progression. These are retrospective data, but I think this is the beginning of the potential of providing many of, or at least some of our PV patients and maybe ET later of really treatment-free remission and maybe even cure. The second option, ruxolitinib, we will not talk about the data because you know them very well, mainly very, very effective as second-line treatment in reducing cytokine-related symptoms, particularly fatigue and pruritus. And again, we, in the meantime, do have the 5-year follow-up where we know that 70% of the patients have a sustained response. We cannot expect after a follow-up of 5 years to have an improved survival if you use ruxolitinib compared to best available therapy, because this is much too short. Nevertheless, I think the data are reassuring because we are sure that we are not increasing transformations or death of patients because of the use of ruxolitinib. Otherwise, we could not say that it improves survival. I think we need decades to make a conclusion. And I think with all the positive data we have, we still have always to consider when choosing treatment, the efficacy on one side and the adverse events on the others. And I will not talk to you about the adverse events of hydroxyurea or ruxolitinib or interferon alpha because you are all more than familiar with these. And I always stress the point, the non-melanoma skin cancer, which is a real risk in patients with PV, ET, or these patients, especially if they had a history and then were put on ruxolitinib. So I think dermatological consultations and follow-ups of these patients is really very, very important. And just to finalize polycythemia vera, I just wanted to give you a perspective of what might be coming next. And this is rusfertide, PTG 300. You know, this is an injectable hepcidin mimetic, which traps the iron within macrophages. And so it reduces the iron supply to the erythrocyte precursors and reduces the production of erythrocytes. And so the hematocrit could be kept low without phlebotomies. And indeed, phase 2 trial data were presented at last ASH. Interesting is that the majority of these patients did not require phlebotomies. And interestingly, you know, the iron stores, the ferritin, the MCV, all this normalized. And we know that many of the symptoms some of the patients on phlebotomy have are related actually to the iron deficiency. And indeed, this was shown in this trial that a reduction in the symptoms, particularly fatigue and the problems with concentrations. And I think they are not because of any modulation in the clinical course of PV, but simply the correction of the iron and the iron stores in the body. Interesting is that this trial was put for a short time on hold by the FDA because of the emergence again of non-melanoma skin cancer cases in patients treated with PTG 300, and then the data were evaluated, and then the FDA released this hold. So these patients in that trial had to be discontinued and then were reinitiated. And at last EHA, some interesting data were presented, what happened with these patients when the FDA had the clinical hold. And not surprising, most of these patients lost the response and the iron stores again were depleted and they had to have phlebotomies. But when PTG 300 was reinitiated as an injection once weekly, again, they regained the response. And actually, with this statement, I would like to come to my conclusion. I think PV is much more than a hemoglobin and a hematocrit. So The role of a hepcidin mimetic remains to be evaluated. And I think, again, like all the MPNs, like all the diseases, we have a lot of choices, and we have to look at all the aspects, the patient, all the social aspects of the patients, the disease itself, the risks, and the treatments available with all the adverse events, with the chances, with the limitations, availability. And we always try, like a puzzle, try to make the best for the individual patient to secure an optimal outcome in a chronic disease. Now, finally, MF, and I think most of the developments are actually occurring in patients with myelofibrosis. And I think we all agree that the introduction of the JAK inhibitors, particularly ruxolitinib, has very much changed the landscape of the treatment of our patients, particularly relating to the symptoms and to splenomegaly. And you know that we have a lot of JAK inhibitors, and I just listed the 4 main with phase 3 clinical trials: ruxolitinib, fedratinib, momelotinib, and pacritinib. And if we look at the NCCN guidelines of last year, we know now or see that 2 JAK inhibitors have been included as main treatment options for both first and second line treatment, namely ruxolitinib and fedratinib. I will not give you any data to ruxolitinib, maybe just the last data presented at EHA again, where what we already knew, that if the patients with MF are being treated with ruxolitinib after a very long time after the diagnosis, the likelihood of survival, I'm talking about survival and not response, is much less compared to patients who are treated with ruxolitinib if the interval between the diagnosis and the start of treatment is less than 1 year. And I think the reason is quite clear, because these patients usually do not have that advanced disease, and they have much better hematological parameters, so they are more likely to have less side effects and more likely to have an adequate dosing and adequate response. But nevertheless, we know we have 2 main problems or limitations with ruxolitinib. One of them is the loss of response we see in more than half of our patients after 3 years. And the second problem is the hematological adverse events in terms of thrombocytopenia, particularly if the patients start ruxolitinib with low platelets between 50 and less than 100,000. And we know that in the majority of these patients, we need to discontinue ruxolitinib and to do drug withholding, despite the fact that we could only treat them with 5 milligrams twice daily. And the response, the red bar below, shows very clearly that the response with this low dose and the discontinuation we have to do because of the thrombocytopenia always is a response limiting factor, and the response is less good than in other patients having higher platelets who are treated with at least 10 milligrams twice daily. And the second issue, and the most frequent cause of discontinuation of ruxolitinib in real life, is actually anemia, where we know that we do have issues with anemia, particularly in the first 6 months under ruxolitinib. And indeed, the major causes of discontinuation were shown to be the advanced disease, transfusion dependency under ruxolitinib, and, as I said, the low platelet count. This is in terms of response, but it is also survival, which is very strongly affected by these factors. And indeed, last year, Passamonti has published a very nice paper showing that the survival on ruxolitinib is much better for patients with higher platelets compared to those with lower platelets. And again, I think the explanation is logical, because we could treat these patients with effective dosing. The patients have less advanced disease, though they have a better response and more durability on treatment. And the same is true for transfusion dependency. This was very recently shown to be a very strong negative impact on survival under ruxolitinib. The more transfusions I have, the less likely we will have a good survival on the mid or longer follow-up. So I think these are the main limitations of ruxolitinib. So we have now fedratinib, at least approved in the United States and in Europe, and I don't know whether it is available in India. And you know, the approval of ruxolitinib was based on the Jakarta trials. First line was the Jakarta. Second line, after failure of ruxolitinib, was the Jakarta 2. On the bottom line, there is no head-to-head comparison with ruxolitinib, but we could say that the response expected under fedratinib first line is similar to that what we know from ruxolitinib, around 1/3 of patients having a reduction of spleen volume by at least 35% per MRI. In the second line setting, we have around 30% of our patients, which is very good for a relapse situation, having a very good response. What is the difference between fedratinib and ruxolitinib, or what is actually the benefit in first line treatment if, you know, anemia incidence is similar, response is similar? I think the main difference is actually that you could treat a patient completely with a complete full dose of 400 milligrams per day, even if the platelets are below 50 and less than 100, unlike ruxolitinib, where we have to limit the dosing to 5 milligrams twice daily. And still, with this full dosing, you will have less issues with thrombocytopenia. And so it is likely that this subgroup of patients with MF in the first line setting are likely to have better responses compared to patients treated with the 5 milligrams twice daily. And you know, the main adverse event of fedratinib was GI toxicity in the Jakarta trials, but I think we have learned now with the prophylactic use of antiemetics, the fedratinib dosing with food, and you know, the modification, drug reductions, really, this GI adverse events have been very much reduced, as I will show you right away. And we have to remember that some patients we have to look for signs of encephalopathy, Wernicke's encephalopathy, and we have to monitor thiamine. And as a practical issue, because monitoring thiamine levels is not easy in real life, I give my patients on fedratinib thiamine. Vitamins are loved by patients. And so I avoid the issues of having thiamine deficiency and the risk of getting neurological complications. And all this improvement in the management of adverse events has been shown very nicely in the data presented at last EHA and last ASH from the Freedom trial, which has implemented all these GI mitigation strategies. And with that, you see from the more than 60% GI adverse events of the Jakarta trial, we only have 20% adverse events if we consider these few clinical aspects in the first weeks of treatment. Additional, we will have some new things coming soon, and actually we have momelotinib and pacritinib as further JAK inhibitors in second line option. And actually, pacritinib has recently gained approval by the FDA for second-line treatment. And I think momelotinib will follow very soon. And one of the highlights of the last EHA was actually the Momentum trial, which is a phase 3 trial, which randomized patients with symptoms and anemia between momelotinib versus danazol as treatment options for anemia. And the highlight of this trial is not the response in anemia, but actually that the FDA and the EMA have accepted for the first time symptoms as a primary endpoint. And you could see that it is no surprise, momelotinib was much more superior than danazol in achieving this symptom response in around 25%. We're talking about second line setting. Please remember, this is second line setting. But also the transfusion rate. Many patients who were transfusion dependent become transfusion independent if they are treated with momelotinib. And interestingly, also you could use momelotinib in patients with low platelets as low as 25. So those cytopenic patients, I think with momelotinib and with the expected approval next year, because these data have been submitted to FDA and to the EMA, we will have a chance second-line treatment, particularly in cytopenic, anemic, transfusion-dependent, or thrombocytopenic patients. What about pacritinib? Pacritinib has, again, good data from the different clinical trials that have been conducted, and we know that pacritinib is very interesting, particularly in patients with very low platelets, below 50,000. this is a real option for these patients, even if they are platelet transfusion dependent. And you could see that despite this very low thrombocytopenia, MF-related thrombocytopenia as an adverse event is not that frequent. So you could treat with a full dose, 200 milligram twice daily, these patients with very advanced myelofibrosis, very low platelets. As I said, this has been approved in the United States. In Europe, we only have a compassionate use option, and we hope to have approval in the coming time. But again, so one should remember, momelotinib is very good for anemic transfusion-dependent patients. Pacritinib is a good second-line option for severely thrombocytopenic patients. But still, we just don't have to talk about JAK inhibitors. There are non-JAK inhibitor therapies that are very interesting, again, as second-line treatment. One of them is the MDM2 inhibitor, KRT232, or the imetelstat telomerase inhibitor, because for both of these, we have phase 3 clinical trials going on in patients who have been previously treated with ruxolitinib and were refractory or relapsed. You know, to naftamadlin, this is KRT232. We have shown the data as a clinical proof of concept of a phase 1/2 trial. We presented at EHA 2 years ago. And we have now the phase 3 Boreas trial going on. And if you are interested, the European MPN Hub will have in the Clinical Trial Club a very nice live webinar on the 19th of July where Laura Michaelis from the United States and myself will discuss about the MDM2 overexpression inhibition and the efficacy of naftamadlin in patients with myelofibrosis, refractory or resistant to ruxolitinib. What about imetelstat? The phase 2 trial were published, very nice data. It is a telomerase inhibitor, it is an infusion, and there is strong evidence that there is a survival benefit in many of these patients. So the phase 3 trial is actually having survival as a first and only trial as a primary endpoint. But I think that the future will not be just, you know, treating a patient with ruxolitinib, wait until we have hematological issues or we have a relapse or progression and then switch to another and another and another drug. But I think it will be the future, the very near future, will be the combination or add-on strategies. That means a backbone, ruxolitinib, like azacitidine in MDS or AML particularly, and then we use all the other classes of drugs we have to potentiate the effect of the main backbone, namely the JAK2 inhibitor. So we have two options. Either we start from the very beginning with 2 drugs, or we start with the JAK inhibitor, wait for at least 3 months, see how the response is, and if it is not adequate, we add the second drug. And this is, to be honest, my favorite because, you know, a sequential approach seems to be very reasonable to manage adverse events as well. And indeed, as you could see, there are so many trials, phase 3. These are only the phase 3 trials and testing this either combination from the very start or the add-on strategy. And I just want to highlight 2 issues that were presented at last EHA, namely the BET inhibitor, pelabresib, which is very interesting. And we can see that in patients, if you combine the BET inhibitor with ruxolitinib, you have a response of almost 2/3 of patients in terms of spleen, but also very good response in terms of symptom control, and even a high increase in hemoglobin. The results are better than if you use the sequential, but you have to be careful. This is the phase 2 trial. As the phase 3, the manifest 2 is just running on, and we have to prove these data in a large phase 3 trial. But nevertheless, this is quite interesting. What about luspatercept? Again, very nice data, especially if the patients are on JAK inhibitors like fedratinib, ruxolitinib, main issue anemia, transfusion dependence under ruxolitinib. And if you add luspatercept, which we all know very well from MDS, 5q minus, ring sideroblasts, the the response is very nice. This means that with luspatercept, it is an injection every 3 weeks. It is very good tolerated, and the phase 3 clinical trial is going on. And, you know, it is a really exciting trial. And if it proves positive, then this will be a real option for our patients whom we treat with a JAK inhibitor and then get anemia or transfusion dependence. And as I said, the trial is going on. I personally love this trial because it is really very, very promising. Finally, data to navitoclax and ruxolitinib, which were again updated at EHA, but they were very recently published, again, the data of the phase 2 trial. Navitoclax, you all know it from the sister venetoclax. The issue is here thrombocytopenia, so we could only treat patients with platelets above 100. Nevertheless, again, a promising treatment combination strategy. So I think the conclusion is with ruxolitinib, I think we have to think of treating earlier, treat adequately. Nevertheless, so many is going on so that we have now approved drugs for second-line treatment. We have many more drugs coming, and I think that the near future will show whether combination of drugs or add-on strategies will really be the future in the treatment of patients with myelofibrosis. And with this, I come to the end, and thank you very much. Thank you, and happy to take your questions.
Thank you, Dr. Haifa. That was fantastic. You really updated us in all these 3 disorders of MPN. So we have colleagues here from India. They may like to ask you questions. Yes, Dr. Roshni.
Good evening, ma'am. Thank you for that very lovely lecture. For patients who are eligible for transplant but who are happy to continue ruxolitinib, what is the timeline one should give them to go for transplant?
This is the €1 million question. You know, if we take the guidelines, with all respect, ruxolitinib should be a bridging, not more than a bridging treatment to transplant. But as you said, patients become very reluctant if they respond to ruxolitinib to go to transplant with all the treatment-related morbidity and mortality, particularly in patients with MF. And to be honest, I myself have difficulties now. I always search for a donor. I discuss these issues with the patients, but what I have learned in the past decade, that I do not send my patients automatically to transplant. And you know, MF is a chronic disease, and we could follow our patients very nicely, and usually the patients do not progress overnight. And as soon as you had the feeling that the patient is not doing that well, not waiting for full progress, because we know if they fail ruxolitinib and you don't have an alternative and you take them to transplant, the responses will be very bad. But I try, as I said, a €1 million question. I try to, you know, watch these patients, discuss all these issues, and believe me, I'm sending only a very, very few patients to transplant nowadays. But again, point and not wait until they go to accelerated or blast phase. But I don't take patients immediately to transplant. And as I said, I always try to weigh, you know, how is the clinical course? And yeah, difficult answer. Individual, really individualized.
And is there any difference in the efficacy of the dose of 20 BD, 10 BD, and 5 BD of ruxolitinib? Difference in the efficacy?
Yes. 5 milligram BID is really, we know that it is really significantly less effective. And I see a lot of patients refer to me because of ruxolitinib failure. The first thing, before I call them, I check the dosing. You have to give it twice. And really the minimum dose for a mid and longer follow-up are 10 milligram BID. And that's why really, if you cannot tolerate this because of, you know, hematological adverse events, then I always consider switching these patients to another treatment.
I find some people use steroids for the thrombocytopenia, is there actually any role of giving prednisolone with ruxolitinib to maintain the platelet count?
Yes, you could try that, but it's really not very helpful. Sometimes, if there is a response, that's something I do. If the patients feel very hard symptoms, or I try to, taper ruxolitinib, I give 20 to 30 milligram prednisolone over days, particularly in those low platelet patients. But on the long run, you might have, for 2 weeks, a rise of platelets, let's say from 30 to 45. But, this is not a sustainable effect, and it is very, very limited.
Thank you so much, ma'am.
Thank you. Dr. Chirag.
Yes, good evening, madam, for a very nice cover of all the new issues and good clarity for old issues. To just clarify again, for low risk ET, you mentioned that no treatment for any numbers like a platelet count of say 800,000. Also no.
No.
More than
No.
Between 1 million and 1.5 million.
Between 1 million and 1.5, I always check the von Willebrand activity. If the von Willebrand activity in a patient not bleeding, sure. If the patient is bleeding, I think we don't have to discuss about that. We start treatment irrespective of von Willebrand. If these patients have a major surgery planned, again, I would reduce the platelets prior to surgery, because I always have seen these patients post operation to have severe bleeding. So I always try to send these patients to operations below 1 million. But otherwise, no. So, the von Willebrand, sorry, just to the one, very practical aid. If it is below 30%, then I know that they have an increased risk of bleeding. I stop aspirin if they were taking aspirin and do cytoreduction. Otherwise, I keep them and watch them only.
So once again, so if the count is less than 1 million, you don't even do anything for surgery also. You would let them go for surgery.
I would not do anything, yeah. I have, for example, now recently a patient having a planned hysterectomy with 700,000, whom I'm not treating. I checked the von Willebrand because, this is cheap, easy, fast. And she had 70%, so I was very happy. I told her, go and do the operation. So if you have major surgery, I think it is justified to check it even if it is below 1 million.
Do you treat white cell count in these patients, say if it is just around the border, 10,000, 11,000?
In ET, we are talking about ET?
In ET, yes.
No, I look at the clinical course, because in ET, there is no real cutoff. It is the dynamics rather than value. So if you have a patient with time increasing platelets, and I would, as I said, not one single white blood cell count, but the clinical course. If you have progressive leukocytosis, this has been shown to be associated in ET patients with thrombotic events. Then I would treat, but not automatically just because of 13,000 once. No.
A related question, not a confirmed PV, but some patients who have hematocrits of 60, hemoglobin of 18, smoker, familial hemoglobin on higher side, and 18, 19, if they stop smoking for a time being, goes like 1 or 2 grams reduction. How do you treat these people? How do you follow them?
Are they JAK2 mutated or
no?
JAK2?
No JAK2, bone marrow also, no signs of MPN.
Yes. I actually had some slides to show this, but because of the length of the presentation, I didn't want to bother you. But we have published this last year. To me, there is no triple negative PV. So what is the differential diagnosis? I'm sure you do check cytogenetics in these patients, because sometimes, if they are not BCR able, you check them always, because we are missing a lot of cases with BCR able in Germany, because everybody is doing next generation sequencing and forgetting the BCR able and classical cytogenetics. Third, mastocytosis. Check the tryptase in these patients, because for me in Germany, all cases are mastocytosis if they are triple negative until proven otherwise. And then PV, you have so many hereditary causes of PV, particularly cousins marrying cousin. And so you have, for example, the EPO receptor. We have published, this is a very nice paper. And then have other non-malignant diseases like cold agglutinin, for example. These patients usually present with enormously high platelets, anemia, and they have the cold agglutinin. So think about non-malignant, and as I said, for PV, and I think in India you have many of these families. The hereditary causes, we do, send them to our cytogenetics, and they do the EPO receptor mutation is very frequent, and it is very important to identify these patients because they don't have a malignant disease, and I just send them to the blood to donate blood regularly, and the issue is solved. No triple negative PV, no.
So if you don't have these testing, you're suggesting that we still reduce their hematocrit?
No, I usually don't stick. This is a big discussion. We have to have a separate webinar because, I am not really a friend of this sticking absolutely to 45%. This is above 50. I will say 50 and above, because we know from the physiology of erythrocytes and in patients with chronic obstructive lung disease, it is actually 55 and above, causing the hyperviscosity and thrombotic events. So in these patients, I tolerate 48, 49, even in classical PV, to be very honest.
Thank you.
Thank you. Dr. Verma.
Thank you, ma'am, for this nice talk. I just wanted to know, in your experience, how common is acquired von Willebrand disease in patients with ET, and how do you manage them?
As I said, it is not seldom. It is not seldom. The higher the platelets, I would say that 2/3 of patients above 1.5 or 2 million will have a von Willebrand activity, if you measure it from the antigen, less than 30%. So it is not really that uncommon, because we do test, as I said, frequently. And so especially if the patient is taking aspirin because of microvascular disturbances, you should be careful, because sometimes patients go to operations without telling you, and then you have massive bleedings. And unfortunately, I do see some of these patients. When the surgeon calls me, I said, why didn't you call me before you operated the patient? And really huge hematomas intra-abdominally with huge problems. So it is always wise testing it, especially prior to major surgery or when the platelets start to become particularly above 1.5 million.
And how do you manage, like, along with cytoreduction, any other supportive?
Yes, because if you don't have another risk factor, and the hydroxyurea is more than adequate. Hydroxyurea, for a very short time pushes down the platelets. And for example, if you need it prior to surgery and afterwards, you could see, because I don't automatically treat 1 million with hydroxyurea. But if the patient is younger, if you have the option, I love interferon, to be honest. Low dose interferon, regulated interferon, you don't need to use Besremi, it is not approved even in Germany for ET. I give these patients 45 micrograms once weekly, and the majority of patients, we have very rarely adverse events because of the low dose, and the patients are responding. You have the normal, not going zigzag blood picture. It's beautiful. And the patients can get pregnant, can lactate, can do whatever they like. It's a very comfortable drug, not only for the patient, but also for the doctor.
Thank you, ma'am.
Thank you. Dr. Radhika.
Thank you, ma'am. That was a very lovely presentation. Madam, myeloproliferative neoplasm is a prothrombotic condition. So do you recommend a prophylactic echosprin in all cases, irrespective of cerebrovascular incidents?
No, not in all patients, no. Because we always have the risk of bleeding also in these patients, right? So we look at cardiovascular risk factors, as I said, it is very, very important, but I don't give prophylactic aspirin to all patients without a reason. That's something I don't do.
Thank you, ma'am. I have a second question too. in a high risk essential thrombocythemia, how do you initiate? I mean, what is the dose of hydroxyurea you initiate the patient on, and how do you titrate it? Do we titrate it to
Yes, this is a
normalize the
very,
platelet?
yeah, I don't normalize the platelets. As I said, the reason for me are never the platelets. If they are below 1 million, I never start with any cytoreduction because we don't have any correlation that treatment with hydroxyurea correlates with the risk of thrombosis if the platelets are, elevated. And the only indication for the platelet count and hydroxyurea is actually, as we have said, very high counts with the risk of bleeding and acquired von Willebrand. I usually start with low dose. I start with 1 gram, actually with patients twice to 5 times weekly because of the adverse events first. And when patients get adverse events in the beginning of a treatment, they will refuse the treatment. But generally on the bottom, and then I titrate based on if the platelets go below 1 million and the patient is feeling well, I will not push the dose of hydroxyurea to normalize the platelets. Normalizing platelets is only within clinical trials as a surrogate marker of I don't know what. But otherwise, in real life, there is no correlation whatsoever between thrombosis or whatever. So hydroxyurea, I use always the minimum to, as I said, reduce the risk of bleeding or try to reduce symptoms. And in the case of symptoms, hydroxyurea is not that effective, to be honest.
If the patient, if I need to give a clearance for some surgical intervention in a patient with ET, can I comfortably give a clearance at a platelet count of 8 lakhs, 7 lakhs and all?
Sorry, to give them what?
Any surgical patient and for surgical intervention, and he's referred to us for clearance. Can I clear the patient for surgery at a platelet count of 8 lakhs, 9 lakhs and all? Can I do that comfortably?
You can do that comfortably, but as I said, if you could, just check the von Willebrand activity.
Oh, yeah, sure. Okay, ma'am. Thank you, ma'am. Thank you very much.
Dr. Akanksha.
Hello?
Yes, go ahead.
Yes, ma'am. Thank you, ma'am, for the talk. So I'd like to ask, how commonly do you come across pancytopenia in patients of myelofibrosis, and how do you approach these patients? Any additional investigations to rule out autoimmune causes or secondary causes? So I'd like to know your approach for these patients.
Yes, if I have, cytopenic patients, it depends. White blood cell counts in MPN to be reduced is really rather uncommon, and I would say very rare. And if you get low white blood cell count, below neutrophils, below, 2 or 3 actually, then you should be very careful. Is this really a case of myelofibrosis, or are you really dealing with a very advanced, going in the direction of transformation even to AML, or are you having MDS, MPN? This is very uncommon. Anemia is very common. We know that around 50% of our patients are anemic within 1 year of diagnosis. I'm talking about MF. And that around 20% will become transfusion dependent within the first 3 years. So anemia is a very common cause of MF. Nevertheless, before attributing anemia automatically to MF, I think we should do the basic workup to exclude simple causes. And we have seen that all the time, folate deficiency, for example, in these patients, or vitamin B12 deficiency, or even iron deficiency. If the patient was a PV patient severely and then transformed slowly to post-PVMF and totally iron depleted, then the patient could have anemia, which is related to iron. So I do a basic check at the time of diagnosis to see whether it's really related to MF or there is another cause. Thrombocytopenia is not that frequent. Around 25% of patients have platelets below 100, and indeed patients with severe thrombocytopenia below 50, you see that around 10% and not more of the cases. And again, check if there are other causes, because as I said, over the time you find an associated mastocytosis. You have, which could be treated very effectively. You could have even hemolytic anemia with immune thrombocytopenia. And as previously mentioned, a short course of steroids sometimes helps in these cases. So yes, we do look, and we don't automatically say, but on the average and the big deal, you mainly see anemia as cytopenia in patients with MF at the time of diagnosis.
Thank you so much, ma'am.
Dr. Prashant.
Hello, ma'am. It was a wonderful talk. Going forward with the same question, proven JAK2 positive myelofibrosis, severe autoimmune hemolytic anemia. Doesn't respond to responds to a high dose steroid, but as we taper the steroids, the hemolysis flares up again. Patient becomes anemic.
Good. Yes.
Yeah. So
yes,
such patients, what is the next line of treatment moving forward than steroids?
Yes, did you start this patient on ruxolitinib? Interesting, because I have such a case with severe hemolytic anemia accompanying MS at the time of diagnosis. She had a huge spleen and steroids, as you said, exactly the same story. And then I put this patient on ruxolitinib, and the hemolytic anemia got better and actually never occurred again, because the hemolytic anemia is mostly as a paraneoplastic phenomenon accompanying myelofibrosis. So if you treat the main disease, you could very well control the hemolytic anemia.
Okay, ma'am. Thank you.
Dr. Chirag again. Dr. Chirag, you have a question?
Yes, please. If you can clarify, how long do we control the hematocrit before surgery, and platelet also, if for ET? So
interesting. Yeah, sorry. Yeah.
Just so to emphasize that it's not right away that you can do surgery, but how long? Apparently several weeks we are supposed to control. So if you can.
No. Several days, and as soon as it doesn't take long. That's why hydroxyurea is good, because you really could achieve a very rapid, within 1 week, 10 days, you have the control of platelets below 1 million, and also the hematocrit with phlebotomy. Sure, it takes a little bit longer. And as I said, the hematocrit and bleeding is not a big issue. With a high hematocrit, I don't really care that much about the hematocrit. Sure, I will not send a patient to surgery with a hematocrit of 60, but when you have a hematocrit, let's say of 48, 49, this is not a big issue in surgery. And the platelets, so with the platelets, the platelet drop usually occurs very rapidly under hydroxyurea. And in that case, because I don't plan to give these patients for a long time hydroxyurea, I even start with 2 grams per day. And usually within 5 to 7 days, you have controlled the platelets and you could send your patient. And interestingly, the von Willebrand activity reverses to normal very rapidly, because we do check that just for interest to learn very rapidly. As soon as you reduce the platelets, the von Willebrand activity gets normal again. So it doesn't take long.
So great. So for hematocrit, we don't have to wait. That was our traditional teaching. Okay.
No.
And a lot of patients are concerned about darkening of skin with hydroxyurea. Any practical tips on that? That is their major concern.
Not really, because these skin changes and adverse events are very common to hydroxyurea. This sounds stupid. We advise our patients to use sun creams to protect the skin, because we do have this issue with many drugs actually. But apart from the general recommendations, there is nothing specific to prevent this. Having, wearing shirts and using the sun cream.
Thank you.
Thank you, Doctor. Dr. Ankit.
Thank you, madam, for a very wonderful presentation. I am Dr. Rekha. I'm a molecular pathologist. So my question is, I got 2 cases wherein we saw positivity of both JAK2 as well as BCR-ABL in an MPN case. So how common is this concurrent positivity of both the markers?
About 10% of patients that are JAK2 mutated might carry another mutation. As I said, KIT mutation, the mastocytosis, c-KIT mutation is very common, also in 10% of patients. BCR-ABL and JAK2 mutation is also not that rare, and that's why it is so important to always have, even if you say this is 100% PV, to do the BCR-ABL. And you know, interesting is, we have just last week, a colleague called me, a patient for years as a patient of PV, and then this patient was put on interferon alpha, and she was ruxolitinib psori, she was an elderly lady, and she was responding nicely, and then she started to lose the response. And you know, we think about progression, and we did a molecular diagnostic again, and to our surprise, she was BCR-ABL positive, proven at the initial time of diagnosis, she was BCR-ABL negative. So either the lab had some kind of a mistake, or indeed the lady did develop the BCR-ABL translocation later. So I think this is also an important issue, always to reconsider our diagnosis. Because as I said, I always get these cases refractory, but sometimes you just have to recheck, what have you done, what didn't we do? And then you could find simple answers like a BCR-ABL, and you could treat the patient very effectively with a tyrosine kinase inhibitor.
All these cases are at diagnosis present for both the markers, or they are PV and they develop later the BCR-ABL and they become CML?
Right, because it depends on the proliferative advantage of the clone. What clone is dominating? This is something we have seen also, you know, at the beginning of BCR-ABL, when patients were previously not having adequate treatment prior to imatinib. And interesting was, you push down the CML clone, and then the MDS or CMML clone cytogenetically comes up. And this is again the case. You know, you think you have a JAK2 mutated PV, you start with phlebotomy, with hydroxyurea, and so you reduce the PV clone, and both the CML clone comes up. Yes.
Thank you. Dr. Prashant?
Hello, ma'am. This is now regarding polycythemia. Some of these elderly patients with polycythemia will have to undergo coronary bypass surgeries. So in that kind of situation, they have a high hematocrit. What is the role of autologous transplant? You collect the blood upfront and keep it and use it during surgery. Is it advisable?
No, we don't do this.
Okay.
We don't usually use this. This is too complicated.
No.
Okay, one last question from the audience. Can we use ruxolitinib for CALR mutated myelofibrosis with severe thrombocytosis refractory to hydroxyurea and interferon?
Yes, we could definitely use, as I said, we call them JAK inhibitors and not JAK mutation inhibitors. So the response is seen in patients with alloretically mutated in triple negative, although I always doubt the presence of triple negative, as I said, but nevertheless, and indeed, even in MPL mutated patients. So yes, you could use them, and the response is quite effective, just like all other mutations.
So you said you always doubt triple negative cases, is it?
I always recheck, and believe me, as I said, we have published that very interesting collection of patients, and I'm always seeing, because I always see daily almost refractory from colleagues. And to be honest, I have only one real true triple negative myelofibrosis patient until now. You know, there are a few, definitely. But if you see a lot, especially PV, as I said, for me, there is no triple negative PV.
Thank you. Wonderful. A very long question answer session, but beautiful, lovely. And, we have Dr.
Thank you. Thanks so much. It's really a pleasure.
Dr. Manoj will give the option.
Always a pleasure.
Thank you, ma'am. Thank you indeed. A big round of applause for Dr. Haifa Kathrin Al-Ali. Ma'am, you were being heard live from delegates from India, Australia, Egypt, Indonesia, Myanmar, Malaysia, Sri Lanka, Bangladesh, Singapore, to name a few. So truly, truly a global webinar as on today. I would also like to thank other two experts who joined in today, Dr. Shahram and Professor David Rees. They were wonderful too. All the expert discussants today, Dr. Sushil, Dr. Roshni, Dr. Cecil Ross, Dr. Selvarajan, Dr. S.P. Verma, Dr. Kunal Goel, Dr. Parth Sarthi, Dr. Prashant, Dr. Akanksha Garg, Dr. Vijita Datta, Dr. Chandran, Dr. Siddharth Shankar Ray, Dr. Sanjeev Gupta, Dr. Tejashwani, Dr. Shyam Agrawal, Dr. Radhika, and Dr. Chirag Shah. I would like to remind you that tomorrow is day 5th of this marathon web series, and we have again 3 experts, Dr. Janis Kappelmeyer from Hungary, Dr. Andries Tiet from Germany, and Dr. Elizabeth Abruzzi from Italy. I would also like to say a big thank you to Teacher of Teachers, Professor Dr. M.B. Agrawal, for hosting it and continuing with this marathon web series. Thank you, and all of you have a wonderful evening and good night.
Thank you. Thank you. Bye-bye.